Okay, it's 8:03 and we're going to go ahead and get started. Good morning and welcome. Thank you for joining the Michigan Opioid Collaborative's Introduction to Treating Patients with Buprenorphine. We're very glad to have you here this morning. My name is Melissa DeMars and I am the Behavioral Health Consultant for the Upper Peninsula for the Michigan Opioid Collaborative. I also cover Lenawee, Monroe, and Washtenaw counties. Joining me is Tim Hudson, who is the Behavioral Health Consultant for Northern Lower Michigan, as well as Wayne, Oakland, and Macomb counties. And we have, of course, our presenters, Dr. Eliza Hutchinson, Dr. Jonathan Morrow, and Dr. Sheba Sethi, who I'll introduce shortly. Just a couple of housekeeping items. We are offering continuing medical education credits, or CMEs. You can scan the QR code that's currently on your screen to obtain the CME credits. We're also offering CEUs for social workers and MCBAP credits for those who are certified or seeking certification through MCBAP today. We will email all attendees a PDF with these links to obtain all three of the continuing education credits shortly after the webinar today. And we'll also be dropping this PDF in the chat throughout the training this morning. This is the agenda for today. The training is from 8 a.m. to 12 p.m. Eastern Standard Time. We'll have a break around 10 a.m. Please, if you haven't signed into the chat, please make sure you do so that we can ensure you receive the presentation slides and anything else shared during our time together this morning. Also, we'd love for this to be as interactive as possible. With that said, please make sure you're muted when you are not sharing. You can use the raise hand function or enter any questions into the chat and we will help get your questions answered. We are going to wait until the end of each section and we'll have Q&A time in between each section. I'm going to do a brief overview of the Michigan Opioid Collaborative, or MOC. We're an interdisciplinary team supporting providers and communities to increase access to office-based addiction treatment, expand care, and improve quality of care with patients with opioid and other substance use disorders throughout Michigan. We're grant funded through Blue Cross Blue Shield and the Michigan Department of Health and Human Services. We offer free same-day consultation services to prescribers to help provide evidence-based quality addiction treatment. Our team of specialists are available to help with patient case questions related to treatment and management of substance use disorders Monday through Friday, 9 to 5 Eastern Standard Time. We provide support for diagnosis, treatment planning, and medication management for patients with substance use disorders, including pregnant and perinatal patients. We also offer help with implementing medications for opioid use disorder into your treatment setting. Like this training, we offer quarterly buprenorphine trainings. These trainings are 4 hours and CMEs, CEUs, and MCBAP credits are available. We also offer webinars on a variety of educational topics such as addiction, stigma, healthcare, and substance use. Many of our webinars also offer continuing education credits. All of MOC's trainings and webinars that offer CME credits do count towards the new 8-hour required substance use disorder training for anyone with a DEA license. And also notice the MOC YouTube channel link. You can watch any of our former trainings and webinars through our YouTube channel. And these slides will be sent out, so you'll have all these clickable links. We also have a hepatologist on our team who offers hepatitis C treatment consultation within 48 hours, facilitates a biweekly case consultation group to review cases with providers, and has developed a 3-part webinar series on hepatitis C treatment, which is available on our website. We've created toolkits for providers to have more resources when treating patients with multiple substance use disorders. All of our events, toolkits, and other resources are available on our website, and we will drop that website into the chat here in just a few moments. So what we do for providers, we offer education and training on medications for opioid use disorder and medications for addiction treatment. We provide technical assistance to providers on clinic setup and educational webinars and same-day patient consultations. For communities, we have behavioral health consultants that mainly reside within the regions they serve. They outreach to providers and clinics throughout their regions to offer support. Additionally, we attend local coalition meetings to provide updates on the MOC, provide training and education on medications for opioid use disorder and other substance use disorders, and connect with these groups to stay up to date on current substance use disorder related trends in our communities. So you can initiate a same-day patient consult through your local behavioral health consultant or on our website. The behavioral health consultant triages the consult and forwards to the Michigan Opioid Collaborative physician that's on call. The physician on call will contact you that same day or at your convenience. Just a note, you do need to have a completed provider sign up on file with us before using the service. The provider sign up outlines what to expect during a patient consult and indicates providers from your clinic that you can initiate a consult. This does not bind you to use our services. It's just nice to have on file so you don't have to complete this when you're trying to initiate your first consult. And I will put this PDF in the chat when we get to the section with case examples. Sorry, this is a map of the behavioral health consultants by region, as well as our contact information. And you can see who covers which area. These are our list of physicians. Specialties include family medicine, chronic pain, psychiatry, obstetrics and gynecology, and infectious disease. And I'm going to stop sharing my screen now and introduce our presenters. Dr. Eliza Hutchinson is a family physician in Ann Arbor, Michigan. She completed medical school at the University of Washington School of Medicine and residency at Swedish First Hill in Seattle. In Seattle, she provided primary care for people living unhoused, those with substance use disorders, and justice-involved individuals. She also served as clinical site director of the Seattle STEP Clinic, a collaboration between multidisciplinary community agencies providing medications for opioid use disorder in a low barrier harm reduction model, and clinical site director for the Recovery Cafe Health Resource Center, a nursing-based outreach clinic serving individuals in recovery. She currently provides primary care at Briarwood Family Medicine and addiction medicine services at Packard Health. She is an enthusiastic advocate for harm reduction principles, innovative models of care for marginalized populations, and decreasing stigma for individuals with substance use disorders. Jonathan Morrow received his MD and PhD in neuroscience from the University of Michigan, where he is now an associate professor of psychiatry. His laboratory research focuses on the neurobiology of motivated behavior, and since 2011, he has provided medication management and other clinical care to patients through the University of Michigan Addiction Treatment Services, or UMATS. So I will go ahead and turn it over to, who will be starting the first section?
I think I'll be doing the intro, Melissa.
Okay. Are you able to share your slides, Liza?
Let me attempt to do that. You tell me if I do it successfully. Okay. Can you see that?
Yes, we can see that.
All right. Fantastic. Great. Well, thank you everybody for being here. Hopefully everyone has their caffeine at their side. We're excited to be with you for the next 4 hours. So kind of before we get going, just letting everyone know we don't have any disclosures to share with you all. This is our outline for today, and we have a lot to get through, of course, as was already mentioned, and we often kind of fill up the time, but we really do want to make this interactive, and we want to be sure we're answering your questions and what matters most to you. So kind of as we go through the day, Dr. Morrow and I and Dr. Sethi will be switching back and forth between these sections, so there will be breaks, and at the end of each section, that's where we'd ideally love to take your questions, but please put them into the chat whenever you need, and folks will be moderating that. And if there's something sort of urgent that pertains to a particular slide, they'll interrupt us. Otherwise, we'll try to save questions to the end. So before we dive more into content, first of all, who can prescribe buprenorphine? And what about the waiver requirement that most of us have heard so much about? As most of you probably know at this point, we no longer have to have a specific data waiver registration from the DEA in order to treat patients with buprenorphine for opioid use disorder. At this point, anyone with a controlled substance prescribing license are able to prescribe buprenorphine. And there are now no longer any federal limits on the number of patients that a prescriber can use. And LARA, the Michigan Department of Licensing and Regulatory Affairs, just announced in June, again, that there is no licensing required for buprenorphine or naltrexone treatment, and also specifically not any number of a limit on the number of patients that can be treated. So really much more availability of this across the country, and we're really glad that you're all here to learn the nuts and bolts so that you're able to provide this life-saving care for your patients. Along with the MAT Act that eliminated the waiver, we also got the MATE Act or MATE Act, depending on how you want to pronounce it. This is just a new requirement that requires all licensees to complete 8 particular hours of training related to SUD, accredited education, before they can renew their license. This was effective June of this year, and it's a one-time requirement. And if you haven't read the details yet, there are lots of emails from the DEA, but you may have actually already met it based on some trainings you've already done, and particularly some of the MOC trainings. So we're happy to help you with that if you are not sure whether you have met that requirement yet. So to turn a little bit to epidemiology, most of us are here because we already know that opioid use disorder is a tremendous challenge that our communities are still facing. But let's just recenter ourselves briefly on the scope of the problem. So this is a graph probably many folks have seen, and really what I want to call attention to is these blue lines down here sort of are representing like prescription opioids and also heroin. And we see that they've really plateaued or even decreased their use in recent years. And what we really see is deaths related to high potency synthetic opioids such as fentanyl. This gray line have really skyrocketed. Also worth noting, although we're not going to discuss in detail, is the death rate for psychostimulants are also dramatically increasing, primarily methamphetamine. So worth noting, but won't be the focus of our talk today. Turning to sort of our more local information, Michigan overdose deaths. At the time of this data, which isn't completely up to date to right now, but overdose deaths actually had plateaued somewhat. But among these deaths, we see different communities affected very disparately. So we see that most notably Black Michiganders have a death rate about twice as high as that of white Michiganders. The reasons for this are, of course, very complex and beyond the scope of this talk, but really important to remember. And I think there will be more and more research coming out trying to elucidate this and some of the reasons behind this. This is just kind of death rates viewed another way. But again, we can see that disparate rate of deaths among Black Michiganders really has not only persisted over time, but worsened over time. We're sort of seeing that gap widen between Black Michiganders and others. So with this background data in mind, I'm going to turn it over to Dr. Morrow, who's going to review the neurobiology of addiction before we move on to more about discussing treatments. Dr. Morrow, go ahead.
Okay, so I will try to very briefly summarize the neurobiology of addiction in probably 10-20 minutes here. So addiction is the psychiatric disorder that we know the most about in terms of neurobiology. There's a lot of unanswered questions still, but there is a lot that we know about. Actually, are you seeing the presenter view? Let me see.
Sure. You're good. We're just seeing the primary slides. That's all.
You are. Okay. Okay. Sorry, it looked like that. Okay. So so we do know a lot about the neurobiology, and I'll try to summarize the things that we're most confident about in how addiction works in the brain. Basically, addiction is thought to hijack the normal reward pathways in the brain. So reward pathways, meaning anything that you want to do, is going to be mediated by a few areas in the brain here, mainly by dopamine acting in this mesolimbic system. So just as a reminder, the mesolimbic system, or sometimes called the reward system, includes this ventral tegmental area in the brainstem, which projects dopamine to the nucleus accumbens in the midbrain and the frontal cortex. And so what happens in addiction is the normal pathways of reward are taken over by addictive drugs. is to illustrate that. I'll show you what happens with just what we call natural rewards in the nucleus accumbens in particular. So this is measurement. These two graphs are measurements of dopamine in the nucleus accumbens. This is done in animals, although you can see similar things in humans if you set up your parameters right. So you can see the dopamine level when the animal gets access to food in this case, but it will happen with any kind of reward. Dopamine spikes with the food. And with a sexual reward, you see the same thing. You get a dopamine spike with that reward. And normally what happens is the reward will trigger dopamine release. But the dopamine release is triggered because you've reached some kind of goal. You're feeling pleasure or satisfaction. So anything that makes you reach some sort of goal will then cause a dopamine release. And the dopamine will make you want to repeat whatever experience you just had. So this is a little different from what is often in the popular press calling dopamine a pleasure molecule. It's not really a pleasure molecule. It's more like a desire molecule. So the pleasure causes a dopamine release, and then the dopamine makes you want to do that thing again. So you can see how this is beneficial evolutionarily. This directs your behavior towards things that are meeting your goals. And so with addictive drugs, they do a very similar thing. And you can see that in these graphs here. This is with a variety of addictive drugs, but you know that's really the only thing that these different addictive drugs have in common is that they cause a dopamine release in the nucleus accumbens. And you'll see with nicotine here, you get the nicotine, and there's a big dopamine spike in the nucleus accumbens. Same thing with cocaine, amphetamine, they do this very directly, actually. And even with opioids, you get pretty substantial dopamine spike with the drug. But this is a little different from what happens with natural rewards. And the difference here is that this dopamine spike is not so much caused by the pleasure or the satisfaction that you get from the drug use. This dopamine spike is actually caused pharmacologically by the drug. So, you know, the most simple example is with cocaine or amphetamine, where those block reuptake of dopamine, which happens everywhere, but it certainly happens in the nucleus accumbens. So that's why you're getting a dopamine spike. So in this case, it actually doesn't matter if you got pleasure or satisfaction or reached your goal by using this drug. You get a dopamine release because you use this drug. And even if it was the worst experience of your life and it wasn't what you wanted at all, you're still going to get a giant dopamine spike from that, which means you're going to want to do that again. And so, like I said, it doesn't matter if you got pleasure from that. And in late stages of addiction, you're not going to get pleasure out of it, which you can see kind of illustrated in this graph, which is it's kind of a made up graph, but this is representing the subjective pleasure that someone gets from drug use. And you certainly get pleasure from drug use. This is why most people probably start using drugs, is because you use drugs and you get euphoria as a side effect of the drug. But with repeated use, you develop tolerance to those pleasurable effects. This happens with opioids, but it happens with other drugs as well. And what happens is you take the drug and you go from a normal state to a euphoric state. And then as the drug wears off, you drop down back into a normal state. much lower than you were. And then you take the drug and you get this spike in pleasure again. But the more you take the drug, the less pleasure you get. And you get to a point where you're really not getting much pleasure at all from the drug. And in fact, when it wears off, you're going into a withdrawal state where you're feeling worse than normal, maybe considerably worse than normal. And at a certain point, you're kind of using the drug in order to feel normal. That's the most that you can get out of the drug, but it's not going to cause pleasure anymore. So you get tolerant to those subjective pleasurable effects. And this also happens with a lot of the physical effects of the drug too, respiratory depression, things like that. You get tolerant to those things. But in terms of the desire to use the drug, which is mediated by dopamine, you get the opposite of tolerance going on. You get what's called sensitization. And that's illustrated in this graph. So here we have an animal who is getting an amphetamine injection. And this is a measurement of dopamine in the nucleus accumbens. And so there's two groups of animals, the black and the white. In the white group, these animals get a dose of amphetamine, and you see the dopamine spike happens pretty quickly there, as expected. And in black, these animals are getting the same dose of amphetamine. The difference between these two groups is that for the white animals, that was their first use of amphetamine. For the ones in black, that was their sixth use of amphetamine, the sixth time they've seen it. And you see the sixth time they've seen it, the dopamine release is higher, and it lasts a bit longer. And if it was the seventh time, it would be even higher. If it was the 10th time, it would be even higher. So the more you use the drug, the more of a dopamine release you get in the nucleus accumbens, which means the stronger the desire to use the drug again.
Jonathan, I'm sorry to sorry to
Yeah.
interrupt. There's a quick question. Does this
Okay.
happen with just opioids or benzos as well?
This happens with all addictive drugs. Yeah. It's most pronounced with stimulants, but it really happens with all addictive drugs. It's just sensitization process, as far as we know. So if you think about what happened in the previous graph, you're actually getting less and less pleasure from the drug, and at the same time, you're getting more and more desire to use the drug. So this is why in late stages of addiction, I'll have people just kind of in desperation say, I don't understand why I keep doing this. Why do I keep using this drug? I don't even like it anymore. This is why. It's right here. It's because the dopamine release, their desire to use the drug is being sensitized at the same time as they're losing the pleasure. They're becoming tolerant to all the things that they started using the drug for in the first place. And this is all a subconscious process. The nucleus accumbens is not in your conscious awareness. So all of this happens below the surface. The patient may not be aware of what's going on. They're usually not. But this is what's actually driving their behavior. Okay, but I'm trying to get too carried away with it. But so another thing that happens that's important to understand with this kind of sensitization process and dopamine release is that stress has a similar effect to drugs and natural rewards on this system. It kind of synergizes with it. And so I'll show another graph like this. Is the same sort of graph of dopamine release in the nucleus accumbens. And this is two groups of animals that get drug for the first time. This case is cocaine. So there's the gray and the blue. They're both getting cocaine for the first time. They're both getting the same dose of cocaine. The difference between these groups is that the ones in blue, we've kind of stressed out. And it's not like a big traumatic stress or anything. It's just little annoying things that we've done repeatedly, like tilt their cage or we get them wet, or make it cold in there, or sleep deprive them, these little things that just stress them out. And you see, under those stressful conditions, you give them the same dose of cocaine, they get an earlier release of the dopamine, it lasts longer, so it sensitizes the dopamine response when they're under stress. This is one reason why stress is a big trigger for relapse. There's three main triggers for relapse. One is cues that are associated with the drug. Anything that's associated with the drug is going to trigger dopamine release because it's been associated with that drug, and so it's going to make you want to use that drug again. The drug itself clearly is also going to trigger that same sort of dopamine release. And then stress. Stress is going to enhance any kind of trigger that you have to use drugs. And so it's a major risk factor for relapse. So that's why we have to treat comorbid psychiatric disorders. Those stress the patient out is going to make them much more likely to relapse if they're under stress because they're anxious, because they're depressed. You got to treat those things because they're risk factors. It's also a reason that aversion therapy doesn't really work. This is the kind of old traditional strategy of making people feel so bad about their drug use that they'll stop. What that actually does is stress them out. This is kind of like if you think about those interventions where people are kind of ambushed and surrounded by family members who will sit in a circle around them and tell them how bad they are for using drugs. Typically, that just stresses them out, and it may make them more likely to relapse. So what's more effective is actually rewarding sober behaviors, using that same system, dopamine release within that same system, that's then going to sensitize sober behaviors. That's much more effective. That's like a contingency management, if you're familiar with that type of approach. So anyway, but point is, stress will sensitize the same system. Another thing part of the neurobiology that we should get to is the influence of the prefrontal cortex. So talked a lot about nucleus accumbens, but the prefrontal cortex is the area of the brain right in the front that is, we call it executive control. That is the main thing that's going to inhibit any kind of impulsive desire that you have to do that may not actually be appropriate for the situation that you're in. We get desires to do things all the time, but we're not necessarily going to do them because it's not going to meet our goals at that point. What stops us from acting on those kind of subconscious urges is the prefrontal cortex, that inhibitory control that you get. And in the process of addiction, addictive drugs will increase these subconscious desires, mainly to use drugs in the accumbens, increase cravings and things like that. But it also decreases the ability of the prefrontal cortex to inhibit those desires. So you can think of it like in the non-addicted brain, you'll get memories, cues, things associated with drug use that then bring up this very salient desire to use drugs. That will create a drive to use drugs, but then you have this control system that also gets triggered at the same time and will say, that's not appropriate right now. I'm at work. I have to drive. I have to take care of my kid. Don't do that right now. That's your stop signal. But in the process of addiction, this connection here between the control center and the drive center gets weakened. At the same time as these desires, these urges get stronger. And so when that memory is triggered, you get these very strong desires to use, and there's no brakes. There's no stop signal. So you just go. And the fact that you're at work, the fact that you have to drive, the fact that you have to take care of your kids, it's not enough to stop you at that point. And so you get repeated drug use. So the development of substance use disorders involves multiple factors. And so not everyone who is exposed to drugs is going to develop an addictive disorder. And we know that because, in the United States, especially, everyone is exposed to addictive drugs. We use everything here. We use alcohol, we use nicotine, we use just so many different drugs. And pretty much everyone is going to be exposed to those drugs at one time or another. Not literally everyone, but almost everyone. So that's certainly one component that contributes to substance use. But there's also a biological component in terms of inherited proclivity to use drugs. It runs in families, addiction does. It's about 50% genetic. There's also environmental factors, epigenetic factors that are passed down in terms of the experiences of the parents and grandparents. There's social determinants, things like, for example, early life stress. People who undergo a very stressful childhood, it changes the neurobiology of their brain and makes it more susceptible to addiction. It kind of jump starts a lot of the processes that happen in addiction. So that person is going to be more likely to develop a problem if they're exposed to substances. So all of these things will contribute to drug and alcohol use. It may make it more likely that you're exposed to drugs and alcohol repeatedly over time. And all of that will affect the brain mechanisms that we were just talking about, leading to a substance use disorder. I think that's all the slides for this section. So were there questions on this section that I can address now?
I don't see any in the chat. Any questions for Dr. Morrow?
Yeah. Otherwise, I can stop sharing and turn it over to Dr. Hutchinson.
All right. Thank you so much. Let me share again. Fantastic. Great. Well, thank you so much for that background. So now we will dive more into treatment. And we're going to talk mostly about buprenorphine here, which is the focus of the talk, but we will touch upon naltrexone as well. And just to give sort of, brief language background, when we talk about buprenorphine and naltrexone, I think most folks know, but there are 3 FDA-approved medications to treat opioid use disorder. One of those is methadone, which can only be dispensed in opioid treatment programs that are specially regulated, but in other settings, buprenorphine and naltrexone are available. And so that will be the focus of today's talk. All right, so let's get into a little bit more about probably this diagram that many of you have seen, but I think a really helpful way to visualize these 3 types of treatments for opioid use disorder. And sometimes I will call them MOUD, sometimes MAT, we'll hear both MAT or MOUD, but that generally refers to this pot of medications. So we have, again, 3 FDA-approved medications, and this graph really shows the drug dose on the x-axis, and then the receptor activity at the mu opioid receptor on the y-axis. So that's really sort of the opioid effect, really, that we're seeing. So if you look kind of at that first line, this is representing full opioid agonists. So this is things like whether it's street substances like heroin or fentanyl, oxycodone, but also methadone, which is one of the treatments. These are all full agonists. So sort of, for the most part, the more dose you get, the more response that you get up until very high levels. Secondly, we have sort of the partial agonist bucket, and this is buprenorphine or buprenorphine naloxone, which will be our focus for today. This has early on in its lower doses, it does have some stimulatory effect, some intrinsic activity at that mu opioid receptor. However, it has pretty amazing pharmacology in that the effect, particularly on respiratory suppression, just sort of levels out. And so at some point, the higher the dose you give, you aren't going to get further effect on that respiratory suppression component. As Dr. Sethi will cover much later when it comes to pain, it's that there actually isn't that same ceiling effect. But for our thoughts about treating opioid use disorder, we can know that there is that ceiling effect, and that gives it an excellent safety and to remember. Then we have our third bucket here, which is the full opioid antagonist. So this is substances or medications that sit on that same receptor, but block the receptor, do not actually stimulate it in any way. And this is really what we see in naloxone or Narcan that is given to reverse opioid overdoses, and naltrexone as well. And naltrexone you may hear also called Vivitrol, which is the long-acting injection. And again, we'll talk more about that. So first we will focus on the details of buprenorphine, and then I'll touch on naltrexone at the very end of this particular section. So buprenorphine was approved by the FDA in 2002 as a Schedule III medication to treat opioid use disorder. It is excreted in the biliary tract, but we do see small amounts in the urine, which is detectable in urine drug tests, which is a common way of testing, and we'll cover that more later. Buprenorphine is most typically taken sublingually, although there is also now a long-acting injectable formulation available. But sublingual administration will bypass first pass metabolism in the liver, and it allows bioavailability of about 30%. And we'll talk later about sort of instructing patients about correct administration. And as I noted previously, there is the ceiling effect on respiratory suppression, and this is really important in particular. It's thought to be related to actually an antagonistic effect on the kappa receptor. But really what this means clinically and for all of us is that buprenorphine is very, very safe in most circumstances. So even if someone were misdosed at a higher dose, if they are taking that medication alone, they are not going to have a fatal overdose because of that. So just important to remember as you're getting started that it is a really, really safe medication in most situations. Also, it's usually the buprenorphine is most typically co-formulated with naloxone. And this is added really as a deterrent to misuse. So idea being that the naloxone component, if the medication is taken sublingually in the appropriate fashion, the naloxone portion is actually inactivated, so should not be acting in the patient's body at all. However, if it were to be injected, it would not be inactivated, and it would actually go to the opioid receptors and have that antagonistic effect, and potentially lead to some withdrawal symptoms. A little bit more about receptor affinity, which is going to be important when we talk about how to get started on buprenorphine. So affinity, again, sort of this is how strong is the magnet of that substance or that medication for that receptor. So a really important and unique part of buprenorphine is that it has very strong affinity for that mu opioid receptor. And it's higher than most other agonists, such as methadone, oxycodone, and even mostly higher than fentanyl. And this is really important to know because if buprenorphine is introduced into someone's brain that has other opioid agonists already sitting on that receptor, stimulating it and really saturating those receptors, the buprenorphine will hop right on, kick the other opioid agonist off the receptor and stimulate it, but stimulate it to a lesser effect. And when that happens, this can be known as precipitated withdrawal, which you all may have heard about, and this is something that patients have a lot of fear about. Clinicians have a lot of concern about avoiding this in our patients. And a bit later, Dr. Moore is going to go over how to start buprenorphine. We'll talk about how to avoid this, but essentially this is really just a diagram indicating, right, if someone has, again, their brain receptors with that full agonist, all those receptors are stimulated, the brain's feeling good. And then you introduce the partial agonist, you will still have some stimulation effect, but you're going to have a net decrease in that receptor activity. And that's going to be experienced as precipitated withdrawal. And one important note, I think, counseling for patients and for our own knowledge is that a lot of folks think that precipitated withdrawal occurs because of the naloxone component of Suboxone, or the buprenorphine naloxone combo product. So it's just really important to let folks know that that actually is not the case. And actually the buprenorphine is the reason that you can have precipitated withdrawal, simply because of that partial agonist and because of that very strong receptor affinity. So this is just kind of reminding us what opioid withdrawal looks like and sort of, what you might see in the setting of a precipitated withdrawal, or just as someone is generally going through opioid withdrawal, right? So sort of, and everybody's progression of symptoms is a little bit different, but some really common things that we see. early on, folks will just start to experience kind of feeling on edge, having some cravings to use, just not really being able to focus. That will progress to some more physical symptoms, yawning, sweating, nose running, eyes will be teary, they might feel more restless, sleep becomes very difficult. A bit further, you'll start to see the pupil dilation, sort of that like goose flesh or goosebumps on the skin. People might get a bit achy, kind of feel like they have the flu sort of aches. And then further down, people will often get nausea, will get even more restless. You may start to see some changes in people's vital signs, like some tachycardia. And then sort of in the more severe range, people will sometimes progress to vomiting, diarrhea, much more GI side effects, and really struggle to get up, and they need to just be in bed when they get the most severe. And there is the clinical opioid withdrawal assessment, also called the COWS. And this is something that often gets used in clinical settings, particularly in inpatient settings where folks are getting more monitored. But this is one way of sort of quantifying symptoms and putting people in the categories of, are they in mild, moderate, or moderately severe withdrawal. And this is available online, of course, if you want to have MD Calc or many other calculators will help you go through this with a patient if you need. So as I mentioned earlier, most buprenorphine is co-formulated with the naloxone component, which is inactivated if it's taken appropriately. And these products have various names, which I'll go through in a minute, but Suboxone is the most common. So apologies if I accidentally throw that word in. This table does also show the effects of various routes of administration. So we see, first of all, if dissolved sublingually, which is really what most formulations are intended. We see that the buprenorphine component is active in the body, you get that partial agonist effect, and the naloxone should really be minimally or not at all active. So the patient should not clinically experience any naloxone effect. If the patient just swallows the medication, there isn't really going to get much effect from either thing. You aren't really going to see the buprenorphine effect or the naloxone effect. However, if someone uses it intranasally or injects it, you are going to have the buprenorphine active component, but the naloxone will also be active. And so again, that can sort of either just help eliminate some of the effect of the buprenorphine or potentially give someone some withdrawal symptoms. So advising patients really to avoid doing that because of those consequences. And then also important to know for administration, these medications are not time released. So the tablets and the films can be split. Usually people will cut the films with scissors or a little knife, and the tablets can also be split. And you'll find patients can split them into multiple pieces, not just in half. So those are options as well. All right, moving a little bit more forward, some different formulations, different names that you might hear. So initially we had sort of just the buprenorphine component, actually without the naloxone. And that came in just a couple of different dosages, 2 milligrams and 8 milligrams. This is still an available product, but again, typically not used. We usually lean more on the combination product. And the names that you'll most commonly hear are Suboxone. That tends to be best covered by insurance and Michigan Medicaid. Zubsolv is also an alternative that is fairly well covered at this point by Michigan Medicaid. There's also Bunavail, which I have not administered very often. I'll be curious if anyone here has, but usually Suboxone and Zubsolv or the generic version are what we lean toward. And I guess the last thing to know is just sometimes you may, in terms of picking one of these, typically you start with Suboxone, but sometimes insurance will dictate what you are or are not able to prescribe. And then this is just a table. I will not go through this in detail, something that you can look up later if you absolutely need to, but just sort of converting between these different formulations. And really the main piece that I want to call out is if you are ever switching between Suboxone and Zubsolv, there is some dosage equivalence, but sort of the generic monolingual buprenorphine is the same dosage conversion to the Suboxone films. All right, so brief mention of a fairly new product, which is showing a lot of promise for a lot of patients, which is the extended release form of buprenorphine. This is the current version is called Sublocade. Other forms are coming out as well, but Sublocade is the one that folks are most commonly aware of. And this has been recently approved by the FDA for moderate to severe opioid use disorder. and it releases the buprenorphine product at a very controlled rate over the course of a month. So patients don't sort of experience those ups and downs that they might get with a sublingual administration. And of note, this does not have the naloxone component in it. And this is becoming much more available, although still is not as widely available as we wish, but is again showing a lot of promise for specific patients, and we'll talk later about sort of how you might select that patient. As all medications do, buprenorphine unfortunately does have some adverse or some side effects to know about. These really are the same as all the class effects of other opioids. They tend to be a bit less in buprenorphine just because of that partial agonist effect, however, still common. I think, in my experience, number one is constipation. We see this almost with everybody. So being aggressive with folks' bowel regimens, hydration, fiber, but absolutely feel free to give multiple types of stool softeners to folks as well. Headaches, especially early on, is something that folks will report. Some dry mouth, and we definitely are seeing growing evidence that there can be an increased risk of dental caries for folks. And these may also be a population of people who haven't had regular dental care in a lot of their life. So we're really trying to encourage good hygiene and getting to the dentist as much as people are able, given their circumstances. There is also some thought that there may be an a decreased bone health. So there's decreased osteoclast activity with buprenorphine, but there's not really any great data at this point saying that we should be doing early DEXA scans or changing our screening at all for anybody. But something to keep in mind as well, particularly if your patient has other risk factors for low bone density, you might consider something like an early DEXA scan. Also, like to mention hypogonadism. This is something that will come up with patients often, concerns about low testosterone, right? We see that as a concern in the general population as well. But definitely opioids chronically administered can lead to decreased testosterone in folks. And so that's something that if people are having a lot of symptoms of low testosterone is something worth checking for. Urinary hesitancy will also be reported at some point. I have definitely seen this with folks early on, and it almost always tends to resolve. So if it's not too severe, usually I tend to just advise folks, if they think they're getting a good effect from medication, to just try to bear with it if possible. It usually does get better. And then just kind of boldly down here again, what's different about buprenorphine from other opioids is there's really no clinically significant respiratory suppression due to buprenorphine, sort of regardless of the dose. So again, to reassure you on the safety of the medication. So what are our goals for using opioid use disorder medication? So as is probably mostly implicit, but I think worth going over. So first of all is preventing overdose and death. And we'll go through data later, but buprenorphine is very powerful in both of these arenas. And really our most powerful tool for preventing overdose and death. We also see significant reduction in cravings and withdrawal symptoms. So that's another huge goal, because that is what will typically lead people to relapse. And we're also aiming to block the effects of the euphoric effects of other opioids. And again, because buprenorphine has that strong affinity to the mu opioid receptor, if someone is on buprenorphine and they introduce another full opioid agonist, they do not get the same effect from it. So, a lot of patients will say that they sort of just, they feel like they wasted their money on their other opioids because they won't feel that effect if they have the buprenorphine in their system. As Dr. Morrow really went over, we're trying to help restore that reward pathway that has sort of changed in the setting of chronic substance use. And then just help folks interrupt their cycle of sort of seeking, using, recovering from drug use, sort of that daily treadmill that folks feel like they're on when they have active opioid use disorder. And then overall, we're also trying to improve rates of engagement and treatment. Sorry, we have construction happening outside of our house. So yeah, just trying to engage folks in treatment, and that is partially their substance use disorder treatment, but also then, engaging in other healthcare and taking care of other parts of their health. So how helpful are these medications in achieving some of these goals? So this is just kind of outlining, compared to some patients receiving no treatment. In big studies, we actually see that outpatient counseling alone or intensive behavioral health or even inpatient detoxification services we don't see a difference in overdose rates with those treatments alone. And similarly with naltrexone, actually, or the long-acting version of Vivitrol, we don't see a difference in overdose. So really the one treatment that we see a difference in is the agonist or the partial agonist, either buprenorphine or methadone. So just important when we're thinking about mortality and overdose, this is kind of our number one tool. So glad you're all here to learn about it. So just kind of to think about the effectiveness of each of these a little bit more. This is a number needed to treat graph. So again, just to review, number needed to treat sort of means, you know, we need to give X treatment to how many number of patients in order to either achieve an outcome or avoid an outcome. And so what this is really showing is that buprenorphine has a very low number needed to treat, which means very effective. So we need to treat about 2 buprenorphine patients to have some suppression of their opioid use, retention, and care. About 20 patients with naltrexone to achieve abstinence from opioids. And then just for comparison, things like statins, which we prescribe, at least in the primary care setting, all the time, or blood pressure medications to avoid something like an MI on our heart attack. We need to prescribe those to about 100 patients. So again, you know, medications that we prescribe absolutely all the time in regular medicine are really overall much less effective than something like buprenorphine or even naltrexone. So another great reason to spend 4 hours of your morning talking about this with us. But also really important, right? Patient-centered outcomes. So there we go. So some studies have also shown buprenorphine's effectiveness on several other different outcomes listed here. So there was and these are several randomized controlled trials to higher quality studies looking at buprenorphine doses of about 16 to 24 milligrams, and we'll talk more about dosing later. Just showing that that medication is much more effective than placebo and equally effective to moderate doses of methadone on these outcomes. So seeing abstinence from illicit opioid use, decreased opioid cravings, decreased mortality, improved stability with folks' occupation and their profession, other psychosocial outcomes, and retention and treatment. So really the things that probably most matter in patients' lives, we're seeing that really do bear out improvement if people are on buprenorphine treatment. This is just kind of another way of looking at the effect of buprenorphine treatment. So just a diagram that sort of shows ultimately that even beyond sort of substance use disorder related outcomes, we do see other improved outcomes such as chronic health conditions, particularly HIV and hepatitis C outcomes we see improved, and the large burden of disease of hepatitis C and HIV in populations particularly who are injecting. So we really see those outcomes also improve. We see decreased criminal justice involvement, again, as many of us see in our patients who are not treated. So again, kind of just highlighting medications are really the most effective treatment for opioid use disorder. And without medication on board, regardless of what else the patient is doing for their SUD, they'll have a higher rate of substance use and overdose death rate. So that is sort of our buprenorphine section, and I'm going to briefly turn to naltrexone and a little bit about the pharmacology and treatment with naltrexone here. So naltrexone, otherwise known as Vivitrol, when it's the long-acting injectable formulation. Again, this is, as we've reviewed, a mu opioid receptor antagonist. So it blocks that opioid receptor, so it's on the same spot. It is not a controlled substance of note, whereas buprenorphine and methadone are. So that's an important piece, depending on sort of your treatment setting and your comfort with that. It is an FDA-approved medication also for alcohol use disorder. It's important to remember sort of when counseling folks who may also have concurrent alcohol use disorder that naltrexone may be able to help treat both of those. It's available, as I mentioned, in a daily oral formulation or every 28-day injectable formulation. Of note, it's not recommended for pregnant patients. And a key limitation is that patients who are physically dependent on opioids have to be opioid-free for for a large period of time, so really 7 to 10 or 7 to 14 days, even depending on what opioids they have been using. So that can be a challenge for folks to be able to spend that time going through withdrawal and waiting to get started. It's important to know that treatment, if you're on it, it does decrease opioid tolerance, right? Because that opioid receptor is completely blocked and not being stimulated. So patients do have the risk of a fatal overdose if they were to lapse in their treatment, and then go and use some similar amount to what they did previously. So those are just important pieces to think about when you're thinking about which patients you're going to treat with naltrexone, and also when you're doing counseling with patients, is like being very aware of that monthly cadence, and if they don't have the medication in their system, that they're at a very high risk of an overdose. Again, just reviewing, so the PO and then the IM formulation. So important to note that the oral version, the PO version, is only FDA approved for alcohol use disorder treatment, actually not for opioid use disorder treatment. And again, sort of in part due to that overdose risk, if someone were just taking it every day on their own and accidentally misses a dose and thinks that they're protected, then again, they're at very high risk of an overdose. And it lasts for about 24 to 48 hours, but it's really a daily dosing medication. And then there is the extended release version, which is what is FDA approved for opioid use disorder. And the recommended dosing is every 28 days. However, there are a number of patients who we think metabolize naltrexone more rapidly, and will note that they experience cravings, or even can get an opioid effect if they use opioids after 21 days. So in most patients, it's okay to dose it even up to every 21 days, every 3 weeks. And Michigan Medicaid typically does actually cover that every 3-week dosing. So mentioned, really important to think about who is the right bucket of patients that this will work well for. First of all, patients who don't want to take any kind of opioids or take a daily medication, this can be a great option. Right, there are patients either because of their own experience, just how they feel, or often maybe because of stigma in the community. They don't want to be on any kind of agonist or partial agonist medication. In that setting, this can be a really good option. And this does tend, I'll just say sort of anecdotally, sort of where I was in Washington previously, Vivitrol was not used quite as often, but I think at least where I am currently, Vivitrol is more commonly used because I think there is a bit more community stigma around the agonist medications. So I think depending on your community and the feelings about medication for opioid use disorder, you may get more or less requests for Vivitrol or for naltrexone. If you are going to treat somebody, important to know, if they have some level of stability, are they able to, do they have transportation to make it to their appointments? Do they have a phone that you'd be able to reach them if they miss their appointments? Again, just making sure that they really don't lapse on that medication and think that they're selected. And then also, as we mentioned, people have to be off of their opioids for quite a period of time. And so the right patient is one who's able to tolerate those withdrawal symptoms and get through that, and perhaps have a safe place to stay while they go through those withdrawal symptoms over, their 7 to 10 days of waiting to get started. Liver function is always a question around naltrexone or Vivitrol. Most typically we say as long as AST and ALT are below 3 or 5 times the upper limit of normal, and the person is not having, an acute hepatitis, then it's okay to give the medication. And oftentimes folks who are wanting Vivitrol do have an alcohol use history, so it's really not uncommon to see some abnormal liver enzymes. But again, if it sort of is low level of elevation, it's really considered quite safe. And there are, many instances where even, in the setting of cirrhosis, working with hepatology, they'll still endorse using it if it helps the patient not use opioids or use their alcohol. And yeah, again, just avoiding prescribing if someone's pregnant or breastfeeding. Again, if a patient is on some kind of opioid agonist therapy, or if they have chronic pain and they need Norco, or they need an opioid for their pain, that's not a time to give naltrexone. Also, if someone has an upcoming surgery, for instance, I had a patient in clinic actually yesterday who was ready to get their Vivitrol injection, but I learned that they were about to have an orthopedic surgery in a couple of weeks. So those would be times to consider different medication. And again, contraindicated in any, acute hepatitis or acute decompensated liver failure. Generally, this medication is really well tolerated. Again, if people get side effects, usually they're early and they improve. Common things that we hear is, a headache, some nausea, maybe a little bit of dizziness. Occasionally I've had patients also say they feel maybe just a bit more dysphoric, and whether that is sort of because we're interfering with all the reward pathways in the brain, or also just patients tend to be making a lot of changes in their lives at this moment. So does the dysphoria come from that? But that's another one that is mentioned early on, so things to counsel your patient on. The GI side effects are more common with that oral medication. So if someone's struggling with that, the Vivitrol may do better for them. And you can also start sort of low at usually the dose is 15 milligrams daily, but you can start at 25 milligrams for a few days and then increase from there if people are tolerating it. If folks are getting the injection, a few site reactions that can happen, some pruritus, some tenderness and nodules. It is a somewhat painful injection, a large injection in someone's glute. So usually nurses and MAs who are well trained to do this can give it pretty easily, but it can be uncomfortable at that moment. And then otherwise, the main adverse effect, once again, just to emphasize, is that reduced opioid tolerance when someone's on the medication. So if they were to lapse on their medication and use opioids, they're at extremely high risk of an overdose. So just being able to mention that to folks. I referred a little bit to liver enzymes earlier, but just to return to that. So again, it is metabolized through the liver. So if your LFTs are greater than 5 times normal, really best to hold off, probably use a different medication or consult with a hepatologist if you think that it is the most appropriate medication for folks. There's some evidence that there are, variable rates of enzyme elevations that may not really be clinically relevant. And typically those return to baseline over time. There is no clear guideline about how often you have to check LFTs, and really actually there's guidance that it shouldn't be a barrier. So if someone doesn't want to get their LFTs checked early on or at all, if you don't have suspicion for any severe liver disease, you do not absolutely have to check LFTs before you begin. However, if you're able to, it's great to have a baseline set of enzymes, and then you can check periodically during treatment. So kind of my own personal practice around that is, again, I will try to offer, and especially if I think there are other reasons to check labs on somebody, often, you can check for infectious diseases, and there are other things you may want to check. But if a patient says, I'm a really hard stick, I do not want to get labs, but I really want this treatment, I still do go ahead and give it, as long as I am not seeing signs of physical exam of, decompensated cirrhosis or really worrisome liver disease history. And I should say, if you have questions about that, feel free to consult us at MOC as well. We're happy to talk through that. So administration of naltrexone. So importantly with this one, check a urine drug screen or some kind of drug test, and a pregnancy test if the person has any pregnancy potential. And again, what you're looking for is negative opioids in the urine. And then also really with your history and making sure that there has been no opioid use in the last 7 to 14 days. It's possible that someone used opioids 5 days ago, but their drug test may not show opioids. So really need to check the history and also check the urine drug testing. With your counseling with patients, just again, kind of going over the possibility of precipitated withdrawal if they had used opioids in the last 7 to 14 days, because that drug testing can be inaccurate or just not reflect use from several days before. And the window of time is, again, if you have questions, we're happy to talk through it with MOC consults. With much shorter acting opioids and sort of in the days of when folks were using heroin, not contaminated with fentanyl or other synthetic opioids, really more like 7 to 10 days was a completely appropriate waiting period. I think a lot of us now, if folks are very heavily using fentanyl, are leaning more toward 10 to 14 days. So there's no perfect guidance on exactly how long to wait, sort of like overall clinical picture, but we're happy to talk through that. Again, this is going to be administered only in the gluteal muscle, absolutely not in the arm, which does happen occasionally, but it's a big needle and it's really only effective if it's in the glute. You can have a site reaction, which we mentioned, so important to mention that to patients, and just the person administering it, should administer it slowly to minimize that. And then just some information on storage and that kind of thing, which I won't go through in detail. And then also important to offer folks some kind of identification that shows that they are on this medication. And why that's important is, again, because this is an opioid blockade. If someone were to, be in a horrible accident or suddenly need emergency care, including opioid pain management, a hospital team or a medical provider would need to know that naltrexone was on board. It's a blockade that can be overcome with very, very high doses of opioids that would be administered by anesthesia teams, but someone would need to know that. So there are bracelets, tags, wallet cards, various ways that folks can have some kind of identification. Showing a little bit more about effectiveness for folks of this. So this is really looking at time to returning of opioid use and like in an inpatient detox unit. And this is comparing extended release naltrexone and buprenorphine naloxone. And we just see that overall there is a higher return to use in the naltrexone group. And also, it was harder for folks to initiate with the naltrexone again because of that waiting period. And had an earlier return to use than buprenorphine. So again, it is an effective medication, but all things being equal, it is the buprenorphine is a more effective treatment in terms of decreasing use and decreasing overdose risk. Just a quick summary on naltrexone. Again, benefits. It certainly has strong benefits for people who don't want to be on any opioid agonist therapy. That may be because they live in a housing situation that doesn't allow buprenorphine or methadone, which is a common scenario, or because they just don't like how opioids make them feel. They don't like the side effects. So good option there. No risk of any kind of diversion or medication sharing. It's not a controlled substance, and it's also usually an injection. And there's no risk really of any kind of overdose by the drug itself, meaning the comparison would be methadone. If methadone is used inappropriately, there is a risk of overdose for methadone, but not with naltrexone. This can be administered in many different settings, so that's helpful. And there's the long-acting formulation, so patients don't have to take something every single day, which is also useful. And it can treat both opioid use disorder and alcohol use disorder. So do consider it in your patients with those co-occurring disorders. But again, the limitations, very difficult to start just given that waiting period. Very severe or acute decompensated liver disease is not a time to give it, nor is pregnancy. And then that loss of tolerance to opioids and the risk of overdose if they were to lapse on their medication. So I believe this is my last slide in this section, and then I will turn it back over to Dr. Morrow, but this is just again kind of highlighting that, really the goal of these medications, all of them, is really that, we're trying to stabilize the brain structures that have been so changed and overactivated by the presence of opioids over time. And it really kind of, these medications help folks' brains heal and stabilize, and once folks are able to do that, then they're really able to engage in other forms of treatment that can help them change some of the thought patterns and the behaviors that may lead to substance abuse or substance use. Sorry, I still use the term abuse. And I really liken this to thinking about something like, an SSRI medication, if anyone prescribes those, right, where oftentimes an SSRI can be used along with counseling, but sometimes the SSRI will help stabilize the brain enough that the person has the capacity to engage in the behavioral counseling and other interventions that are going to help them stay stable long term. So I think really stabilize the brain first, and then folks are able to engage in everything else that they need to do for their recovery. With that, I am going to turn it back over to Dr. Morrow, and I will stop sharing my screen. Oh, let me actually see. Are there questions? I'll try to cruise the chat, but anyone call out if I miss a question.
Thanks, Liza. There are a couple and I can read them.
Okay.
The first question is, how is coverage from insurance for Sublocade?
Oh, yes. So Michigan Medicaid is covering it fairly well. I'm less familiar with the commercial insurances. Sometimes I have seen it require a prior authorization, but it usually does go through. So it may not be immediate, but within several weeks, I've usually seen folks get it approved. And if any of the other clinicians on this call or anyone else has more experience with it, I actually have little experience here in Michigan so far with it. So if anyone wants to add anything else about insurance coverage, please go for it.
I bill for it or send it in all the time. I'm sorry if somebody else was talking, but commercial insurances do not pay for it. It's very expensive, but you can get waivers or not waivers, but you can call the manufacturer or you get a representative that will help you and she'll walk you right through it. And they will cover a big portion of it. It's very expensive. Medicare will not touch it. It's not available. It will not be paid for, but commercial insurances is very helpful.
Thank you for that.
The next question is, I'm sorry if I missed this, but do we need to be aware for patients receiving naltrexone as an outpatient, but then have an acute pain, for example, in the ED? Is there a suggested starting regimen? I know you mentioned anesthesia teams needing to be involved for the large amount of opiates required.
Yes, great question. So absolutely something to be aware of if you see one of those tags, or if you're giving opioids and somehow the person's not responding to them at all, something to consider or ask them about. And I have personally never, I believe the doses are so high that you need to have anesthesia involved. And I haven't personally been in that situation, but in what I understand, that the doses are so extremely high that you would need anesthesia involved and some close monitoring. Any of the other clinicians here actually dealt with that situation and want to share? Yeah, so I think if possible, what I'd suggest is, if you were in that situation in the ER and you had an anesthesiologist to consult with, that's what I would go for.
Thanks, Liza. I think that's the last question. There is a comment in the chat from Safa. There are many outpatient providers who will cover it with Medicaid, and I think this is regarding Sublocade. New Urgent Care, NEU Urgent Care in Hazel Park accepts Medicaid for all of these medications.
Great, thank you.
Thank you.
All right, so let me share my screen. There we go. Okay, so this section is going to focus on kind of the practicalities of starting someone on buprenorphine. And the first thing to consider when you're thinking about starting someone on buprenorphine is, are you ready to prescribe buprenorphine? And what we mean by that is, do you have the structure in place to support somebody who's on buprenorphine? So do you have the resources available to provide appropriate treatment to someone who needs buprenorphine? Which includes medical care, which includes psychiatric care. How are you going to get the appropriate care to that patient who needs it? Doesn't necessarily have to be in your clinic, but you need to have some kind of access and a procedure where you can refer people to the appropriate care. Do you have on-call coverage? And how does that work? If patients can't get their Suboxone, they're going to go into withdrawal, and that's kind of an emergency. They're at very high risk for relapse, and at that point, if they go back to the opioid use that they were doing before, they're likely to die. They don't have the same kind of tolerance anymore. So for me, I have a relationship with our psychiatric emergency services, and I tell my patients, if you can't get a hold of me, call the emergency services. I've talked to them. I've explained this is an emergency, and they will help you with the buprenorphine. They'll either get a hold of me or find some way to get you your buprenorphine. And then if you need to refer someone to a higher level of care, to a methadone clinic, to residential treatment, what are the treatment programs that are available in your area? How are they going to accept a referral from you? So you want to think about those things and set that up before you start assessing people for buprenorphine. So assuming you've done that, then you can do your assessment of a patient who you think might need buprenorphine, or just patients in general, because you never know who might need buprenorphine. So just an overview of how you do the assessment. You want to assess for past and present use of drugs, certainly opioids, but also alcohol, other drugs, and tobacco use. I want to, most substance abuse patients actually die of their nicotine use. Even the opioid use patients, that causes it takes longer, but that causes most of the mortality. So don't leave that one out. You want to review the prescription drug monitoring program, that's MAPS in Michigan. So you're actually required to access that when you're prescribing controlled substances now. So that'll give you a list of other controlled substances that they may have gotten from other pharmacies or other physicians. You want to establish whether they have a diagnosis of opioid use disorder, assess for other substance use disorders, identify for other conditions, psychiatric conditions, medical conditions. How are you going to address those? Evaluate their level of physical, psychological, social functioning or impairment. This can be very important in forming your treatment plan. There's a lot of, like, for example, if you're going to refer somebody to a residential program, a lot of those can't really handle people who are very impaired physically. So you want to know that beforehand. And last but not least, you want to determine the patient's interest in participating in treatment. Maybe you think it's a good idea, they may not. And it's pretty rare. It's not totally impossible in Michigan, but it's almost impossible to force somebody into substance abuse treatment if they don't want it. So you'll have to work with the patient and what level of engagement they're willing to accept, as opposed to what you think might be best. So if we think about these, if we just go through those, one that I mentioned was taking a substance use history. This is an example, and you should have access to these slides, but this is an example of the types of questions that you want to ask in a substance use history. It needs to be fairly detailed, both for their opioids and for other substances that they have used or may be using. You want to know all of that to formulate your treatment plan. And I would ask about, so for example here, how old were they when they first used? What's their pattern? Are they using every day? Is it a binge abstinence pattern? How much are they using? What route are they injecting? Are they snorting? Are they, how are they using this? When's the last time all these are very important questions to know before you're going to start a treatment plan with someone. And I would ask about these substances, at least the ones that are listed here. I would ask about these separately, because sometimes you say, have you used drugs? No. What about nicotine? Oh, nicotine, yeah. Oh, cannabis, yeah. Oh, cocaine, yeah. Okay, I didn't know you meant cocaine. So you want to go through these individually, because people don't always understand what you mean when you say, "Are you using drugs?" Substance use disorder treatment history can be very helpful. Have they had periods of abstinence in the past? How did they achieve that? That's very helpful to know what's worked in the past or what hasn't. And then consequences of use gives you a more complete picture of how severe the disorder might be, what kinds of things we need to address in the treatment plan. And so one of the objectives of getting this information, one of them is establishing, do they have a diagnosis of an opioid use disorder? And fortunately, to help us, we have the DSM. We have the Diagnostic Statistical Manual that gives you criteria for opioid use disorder. And this is for all substances of abuse, but this is what it would be for opioid use disorder. You just count up the number of these symptoms that they're having, these conditions that they're meeting, and all of these they're basically different indicators of a loss of control over the substance use. It's not enough that they're just using a substance. That doesn't qualify them as having a substance use disorder. If they've developed an addiction, then they have lost control over that substance use. Most people who use substances aren't actually addicted to it. But once they develop it, you'll see these things like they're using more than they intended. They're not able to stop. They're giving up all these other activities and replacing those with drug use. Those are all indicators that they've really lost control over the substance that they're using. Important to note, and there's a spectrum of substance use disorder. Someone can have a mild substance use disorder. They can have a severe substance use disorder. And the way you determine that in a systematic way is just counting up the number of symptoms of criteria that they meet. And so mild is 2 to 3 of these, moderate is 4 to 5, severe is 6 or more of these. That tells you how severe their pathology is. Important to note that tolerance and withdrawal are on this list. Those can't be the only 2 criteria that they're meeting, though, because that just means that they're physiologically tolerant, that they're physiologically dependent on the substance. That's not the same as addiction. You can get that with a blood pressure medication, which is not addictive at all. So those can count towards your diagnosis, but it can't be the entire diagnosis. It's just based on tolerance and withdrawal. So also important to address co-occurring mood disorders and other psychiatric disorders. This is very common in this population. So 30% of people with a mental health disorder also have a substance use disorder. And for people who use substances and have a substance use disorder, their lifetime prevalence of other mental health disorders is over 50%. So most of these patients are going to have another mental health disorder. In fact, in my clinic, we did kind of an informal survey. It was about 80% of our patients have some other mental health disorder in addition to their substance use. So that's important to those worsen outcomes when people have multiple disorders like that. But it's important to note that, for example, depression, if they have major depressive disorder in remission, that does not worsen their outcomes for substance use disorder. So treating their mental health disorder is going to go a long way to helping their recovery. But you can't treat it if you don't know about it. So you need to screen for that and develop a treatment plan for their other disorders. Sometimes it's hard to figure out whether a mood disorder or other psychiatric disorder is secondary to the substance use. Things that can be helpful for that are asking about a timeline of these symptoms. Did it start before the substance use? That tells you that it may be separate from the substance use, another disorder on top of the substance use. You can ask about symptoms during extended periods of abstinence. So at least 4 weeks, you want to make sure that they're beyond a withdrawal phase. But if they've gone, for a year or something when they're of sobriety, how did they feel during that time? Were they still depressed? Were they still having trouble with concentrating? Whatever their symptoms are, were they still having that during that period of abstinence? And then a family history can also point you more towards a comorbid psychiatric disorder. Like if somebody has first-degree relatives with bipolar disorder, that's going to make it more likely that person's manic or depressive symptoms are actually due to bipolar disorder and not entirely caused by their substance use. But I'll point out, even if it is entirely caused by their substance use, most of these symptoms are going to respond to the same sorts of treatments that you would use in the absence of a substance use disorder. So it's not a reason not to treat somebody if you are unsure whether their symptoms are due to a substance use. I would say to make sure that you're addressing both types of symptoms at the same time when you're treating someone with other psychiatric disorders or symptoms along with their substance use. Okay, but so also very important, taking a social history. You want to understand what the person's housing situation is. What's their employment? What's their financial situation? Do they have family? Do they have kids? Social supports? All of these things are going to be, it's going to influence your treatment plan. That's going to, I mean, if you're prescribing buprenorphine to somebody, do they have a place to store that? Do they have a place? Is it reasonable that they're going to keep track of this medication? Maybe an injectable would be a better solution for somebody who doesn't have stable housing or something like that. It's important to understand their actual living situation and what supports they have available to them and what responsibilities they may have. What legal issues do they have? What religion are they? That can certainly influence their what's acceptable in treatment or what kinds of things would actually dovetail with their beliefs. Sexual orientation sometimes gets wrapped up in, and sexual activity gets wrapped up in substance use. So all of these things are important to know. And one thing to address on as part of this topic is concurrent use of sedative hypnotics. I want to talk about this specifically. So you certainly want to think about all kinds of other substances that they may be using, develop a treatment plan for those things, and try to understand how that may intertwine with their opioid use. But sedative hypnotics is particularly tricky with opioid use because it raises the risk of overdose so much. So anybody who's using opioids, that people overdose on opioids because of the respiratory depression. They'll stop breathing. So opioids lower the respiratory drive. Benzodiazepines also lower the respiratory drive. Barbiturates do, but they lower the respiratory drive, but by a different mechanism. So you put those two together, people are at very high risk for overdose if they're using both of those things. And it's not an uncommon situation that people are using both sedatives and opioids. So buprenorphine, as we've heard, it's very difficult. In fact, it's really impossible to overdose just on buprenorphine because it's a partial agonist that has that ceiling effect. But you can overdose on buprenorphine if you combine it with a sedative hypnotic, if you combine it with benzodiazepines, or theoretically, if you combine it with a lot of alcohol, that's going to lower the respiratory drive in it, and you could put the person over the top by putting some buprenorphine in the system. And so now you've got a person who's overdosed because of the buprenorphine in combination with a benzo. And that has happened, that people have died from combining benzodiazepines with buprenorphine. So would you prescribe a buprenorphine to someone who is using a sedative hypnotic? That's considered a relative contraindication. Now, what I would suggest for people who are using both opioids and benzodiazepines is a referral to medically supervised withdrawal. So inpatient treatment, get them off of these substances and stabilized, and then continue on buprenorphine or something, or methadone, or whatever treatment that is most appropriate for that patient. But the patient has to accept that. And so it's not uncommon for a patient who needs that type of intervention to say, no way, I'm not doing that. But they will consent to outpatient care. So are you going to prescribe buprenorphine knowing that this person could overdose on buprenorphine that you prescribed? A lot of people are hesitant because of the potential liability there. I would say the pendulum has swung in the other direction at this point. You have to consider, what's the alternative? You're going to prescribe buprenorphine. The person is at risk for overdosing on a combination of benzos and buprenorphine. But the alternative that they're presenting you is they're going to use fentanyl. combined with benzodiazepines. That's much higher risk for overdose than buprenorphine combined with benzodiazepine. So by giving them buprenorphine, you're putting them at much lower risk for overdose, even considering the fact that they're using benzodiazepines. And so now the FDA has recognized this. They've put out statements specifically saying that it is recommended that people prescribe buprenorphine to people who are using benzodiazepines. Well, I guess more to the point, you should not withhold buprenorphine from people who are using benzodiazepines and other CNS depressants. So you're at much more risk for someone overdosing because you did not prescribe them buprenorphine in that situation. So always think about, is what I'm doing in the benefit, is that going to make the patient better off? If it is, you should do it. If it's not, if the patient is going to be worse off because of the clinical decision that you're making, make a different clinical decision. You're not going to get in trouble for making the patient safer. Okay, so I spent a lot of time on that, but that's because people have fears about that. The rest of this we'll talk about induction, the actual process of induction or initiation, assuming that you've decided that this patient is appropriate for buprenorphine. How do you go about doing that? And so traditionally, you're going to have this person go into mild to moderate withdrawal. That way they have some unoccupied opioid receptors that then the buprenorphine can bind to without knocking off these full agonists and sending them into precipitated withdrawal. Keep in mind, though, that people on prescription pills instead of fentanyl, they may not have withdrawal symptoms. It just takes a while for those opioids to get out of their system. So that may not show up for a while. The goal of the induction is to titrate your buprenorphine to a dose that is curbing their cravings, and it's minimizing their withdrawal symptoms. While at the same time, they're not having a lot of side effects. They're not getting sedated and all these things that you can get from opioid use. They're just looking for the right dose. That's very common with pretty much any medication you prescribe. That's what you're going to do with buprenorphine. So before starting buprenorphine, you want to review a treatment agreement, get consents, and do a start talking form. So the treatment agreement is just that's a, sometimes people call it a contract or something. It's really just an agreement so that you and the patient have both talked about what the rules are for your clinic and under what conditions you're going to prescribe buprenorphine. That's not required, but it's very helpful to establish that before problems arise. What are the policies that we have, so that you can review that with the patient? Say, look, we talked about this already. This is what's going to, we'll refer you to a higher level of care if these conditions aren't, we've talked about this already. Informed consent is required when you're prescribing these. That's a legal requirement when you're prescribing these substances. And the start talking form, any opioid that you're going to prescribe, you need to do a start talking form that says that you went through the informed consent process. And you talked about including alternative approaches for treating the disorder, and potential side effects, including physical dependence, including neonatal opioid withdrawal syndrome. All of those things you need to talk about with patients before starting. It's helpful to get labs. And there's several things listed here that's helpful to know: hepatitis B, hepatitis C, HIV, pregnancy tests. All of these things are very helpful, but it's not required. You don't need, you shouldn't withhold buprenorphine from somebody because you don't have the labs. That's not a reason to do that. Get the labs if you can. If you can't, go ahead and prescribe. It's better to have them on it. Same thing with a urine drug screen. Very helpful to know. what other things the person might be having. But it's not required to do that. The big thing that you're looking for is, are there opioids in their system? You should have, if you've talked to this patient about precipitated withdrawal, and they understand what's going to happen if they are on full agonists and they start buprenorphine, they're going to tell you. They don't want withdrawal. They've been through it before and they don't want it. And so if they don't want it, then they'll be honest with you about what's in their urine, or at least they won't take the buprenorphine to do that. So that's recommended, but not required that you get that urine drug screen. So one thing that's come up over the years is that's changed a bit is whether you do this initiation in the office or at home. What's called an unsupervised initiation. So in 2020, ASAM put out the conclusion that both office-based and home-based initiation is safe and effective. And there's lots of benefits to people starting buprenorphine at home. In fact, it's pretty rare now that I will start people in the office. And it's because starting it at home makes the patient more comfortable. Nobody wants to sit in the doctor's office for hours at a time. They don't need a driver to take them back and forth. You don't need to delay for scheduling. If they're coming into the office, you have to schedule somebody an appointment for them to be seen and get your staff involved and everything. They don't have to do that if they're just doing it from home. They can do it whenever they're ready. That's less of a burden on your clinical time and resources. They don't have to compromise their anonymity in a waiting room. And it means less clinic-based visits for the patient, which a lot of people put a real premium on that. If they want to come into the office, I'm happy to do that, but most people don't. And that can be a real barrier for them starting this medication that can save their life. So, we would definitely recommend making that available, the at-home induction. They're very familiar with using opioids, and buprenorphine is safer than anything else, any other opioid that they've used. So it's really pretty safe to do that in home. So there's a few different ways of doing a buprenorphine initiation. I'm mostly going to be talking about the traditional initiation, which requires that the patient is in withdrawal, but there are alternatives. One that I'll talk a little bit about is the low dose or microdosing strategy. And there's also a high dose macrodosing strategy that I have not used. I'm not going to talk about that much. But I'll talk about the other two. And this arises because these alternative approaches are important in part because of fentanyl. Fentanyl lasts for a long time in the system because it's fat soluble, and so being off of fentanyl for a long enough time to be in withdrawal and not get precipitated withdrawal, that can be really challenging for a lot of patients. And it can be a real barrier for them starting treatment. And, the reality is now pretty much all opioid use is going to be fentanyl. Whether the patient knows it or not, they're using fentanyl. So that's going to be in their system, and it's difficult to go through a full withdrawal with fentanyls in your system. So what you can do for someone who can't tolerate withdrawal, or it's just unlikely that they'll be able to make it through that whole withdrawal period, is to avoid the withdrawal process entirely by using this microdosing strategy. There's different examples of this published in the literature. There have not been large controlled trials of these, but there have been there's a lot of clinical experience with this. And there have been some published case studies and things that have shown different protocols. So this is an example. The idea is that you start on a very low dose of buprenorphine. And that way you're introducing this partial agonist, but at such a low dose that it is going to displace some of the full agonists that they're on. So they're continuing to take whatever they're, fentanyl or whatever they're taking. But you're adding buprenorphine on top of that. It'll displace a little bit of their full agonist, not enough to put them into withdrawal, but some of their receptors are occupied by the buprenorphine. And then you increase that. So this is going from 1/4 milligram up to 0.5 milligram, up to a full milligram. Day by day, you increase that dose. So effectively, what you're doing is tapering their opioid. And so gradually, you're getting to the point where you're up to 12 milligrams of buprenorphine. At that point, pretty much all of their receptors are now occupied by buprenorphine. So you've replaced that full agonist gradually with a partial agonist. And so now they're not going to get withdrawal anymore. They can stop their full agonist. It's not doing anything because it's just bumping off of the buprenorphine at that point. And then you can titrate the buprenorphine to the appropriate dose. So it's kind of a gradual replacement of the full agonist with a partial agonist that doesn't require the patient to go through withdrawal. Very useful strategy to use. But as I said, I'm going to talk about the traditional way, which does require that the patient is in mild to moderate withdrawal. Again, a lot of patients, that's partly why they have such trouble with the opioids. They can't handle withdrawal. So you can help them to manage symptoms of withdrawal without an opioid. Here are some medications that you can use. It's basically treating the individual symptoms that they're getting. So you want to get from them what are your symptoms of withdrawal, because it's a little bit different for everybody. But whatever their prominent symptoms are, you can treat that with, for example, if it's pain, give them NSAIDs. I probably wouldn't use benzodiazepines for insomnia, but trazodone, something sedating for insomnia. Dicyclomine for abdominal cramps. For diarrhea, you can give them loperamide or something. Clonidine is very helpful for most symptoms of withdrawal. So this hyperadrenergic state, they can make them anxious, they can make their blood pressure go up and down. That's helpful. So pretty much everybody I would give clonidine for symptoms of withdrawal, plus whatever else they need for their symptoms. So for patient instructions, you want to have them abstain from opioid use. In the old days, you could go 12 to 16 hours with the prescription opioid pills. I would say, as I said, all of those opioid pills are actually fentanyl. They at least have fentanyl in them. So they're going to need to stay off of the opioid for at least 24 hours, probably more like 48 or even more hours to make sure that they're in withdrawal. And you measure withdrawal using the clinical opioid withdrawal scale, or they can do it themselves with the self-administered opioid withdrawal scale. Just provide them with that, and they can assess their symptoms, count them up, and you get a score. And if it's over 12 for the cows or over 17 for the sows, then they're in enough withdrawal to start buprenorphine at that point. You want to talk to them about how to dose buprenorphine. It's sublingual, so you have to put it under the tongue with a wet mouth. Can't be dry. That's part of why you can't smoke before using. You have to stop smoking at least 30 minutes prior to using the medication so that your mouth isn't dry. Let it sit there under the tongue until it dissolves. That way it's going to absorb sublingually. You don't swallow it because that's just wasting the medication. It's not going to absorb in the stomach. So you have to explain all that to the patient. Counsel them on the possibility of precipitated withdrawal so that they don't do that to themselves. And then you can prescribe them the buprenorphine. So how much do you prescribe? That depends on several things. You want to think about Typically, you're going to want to give a short prescription because you want to see them back, and you don't want to you want to reassess before giving them a big supply of controlled substance like that. So I'll usually give 3 to 7 days worth to the pharmacy and have them come back for an assessment at that point. That will encourage them to come back to see you if they want to continue the buprenorphine. But you also want to consider, do they have copays? Is that actually reasonable for them to fill prescriptions every few days? You want to have that information so that you're not making an unreasonable treatment plan for the patient. There's also prior authorizations that they may need. That's less of a problem now with buprenorphine, but it has been certainly in the past. And with all of these patients, you should co-prescribe naloxone as a rescue medication. Anybody who's got an opioid use disorder, anybody who's really using illicit substance, even if it's not opioids, they should get naloxone because even if it's cocaine, it would be laced with fentanyl. So they should have a rescue medication. You should train someone who lives with the person how to use naloxone, ideally, because they're not going to be administering it to themselves. But that's a very important thing to remember as well. And they can get that for free in a lot of places too. So you can, without a prescription, so you can inform people about that. Okay. So dosing, you want a relatively high initiation dose of buprenorphine, at least 16 milligrams. That's what is typically needed to help people stop using opioids, prevent a return to opioid use, at least 16 milligrams. A lot of times patients will want to use less than that. There's not an evidence base for treating people with less than 12. And really the evidence is best at least 16 milligrams. Below that, you risk having the patient at this kind of subacute withdrawal state. They're still having some cravings. And so just get them up to 16 as long as they can tolerate that, if they're not getting a lot of side effects. Side effects meaning if they're sedated, or if they're having a lot of constipation or something like that that they really can't handle. That means that they're on too much buprenorphine. But if you're not getting side effects, just go up to at least 16. Oftentimes it's going to be more like 24 if they're using fentanyl. So the official insert recommends a starting dose of 12. As I said, they're probably going to need a higher dose than that, but you want to have it be at least 12, their dose if you can. It's hard to get coverage for over 24 milligrams, and at that point, you've pretty much occupied all their receptors with buprenorphine. So adding more on top of 24 is unlikely to give them any more benefit. So that's a pretty reasonable maximum dose. It's not dangerous to give them more, it's just not going to do anything. So you can give the patient explicit instructions. This is an example of this on how to take this when they're doing the initiation. Once they have withdrawal symptoms, they feel bad, they take their you want to start at a low dose, something like 2-4 milligrams, wait for an hour, and then if that makes you feel better, take the rest, wait again, take some more. If you're feeling worse though, they should call, because that could be a sign that they're going into precipitated withdrawal. Let's see. And with fentanyl, it may take a while for the patients to feel better, again, because this fentanyl it's stored in the fat, it's released inconsistently. So you can counsel patients on that. It may take a while to actually titrate the dose because of the fentanyl pharmacokinetics. And they can self-titrate that dose. They got a lot of experience with opioids, so they can find a dose that works for them. But if they're getting sedated, that means too much. So you can just counsel them on that. If they're not physically dependent on opioids, say they've been abstinent for a while, maybe they just got out of prison, or they just, they're coming to you after they've been successful in withdrawing, or however they did. Maybe they got out of the hospital. they still have an opioid use disorder, but you don't have to worry about precipitated withdrawal. So you can just start the buprenorphine. It's still recommended to start at a low dose just in case they have side effects, but you can just start them right away and titrate up to the dose that they need. So if the patient, we talked a lot about precipitated withdrawal, but if the patient gets precipitated withdrawal, it's not going to kill them. It's just an intense withdrawal syndrome. It's not very common for people to get precipitated withdrawal, although with fentanyl has made that more common because, like I said several times now, it's got this lipophilic property to it, and it's very potent. But if they do have precipitated withdrawal, you can refer them to the emergency room for supportive care at that point. I think I have a strategy. Yeah, so you can manage precipitated withdrawal in different ways. There's not really an expert consensus on how to do that. But one thing you can do is use some of the non-opioid medications that I mentioned before to try to just manage these symptoms, clonidine, NSAIDs, things like that. But the other strategy that's probably the simpler and easier one is to just dose them with more buprenorphine. Give them a large dose of buprenorphine, and try to overcome the withdrawal symptoms with buprenorphine. Get them on it. It's better to do that without going through the precipitated withdrawal, but once that's started, just replace all their opioids with this partial agonist. You can just stop the initiation and have them come back the next day to restart it, but that is unlikely that the patient is actually going to do that. If they've tried this, they got precipitated withdrawal, they're probably not coming back to you. So the way you can kind of salvage that is just getting them on the buprenorphine right then. You'll actually treat the withdrawal symptoms, and now they're on buprenorphine, and you can treat them from that going forward. But the best way is just to avoid precipitated withdrawal. Okay, so day 2, you're gonna take whatever dose they had on day 1. You can split that to twice-a-day dosing. That's perfectly fine. In fact, most patients are going to take it at least, either twice a day, 3 times a day. Seems to work better that way. Theoretically, they don't have to do that, but they like it better that way. And then if they're still having symptoms, you can just add some more buprenorphine on top of that to get their symptoms under control. Remembering to back off if they're getting sedated. And then beyond that, just continue to titrate up or down based on what symptoms they're having. Follow up with them in the clinic. I'd say at least on day 7, ask how did the initiation go, how much are they taking, what's their schedule, things like that. And make sure that you're available or someone is available in case they have problems during this initiation process, at least over the phone. Okay, I'm a little behind. So I will go through this case relatively quickly, but so here's an example. You have Jenny, 23-year-old social work grad student, comes in seeking treatment for heroin use. Right now, she's comfortable. She's not in opioid withdrawals. And she tells you she's feeling anxious most of her life. Started smoking marijuana, drinking alcohol on the weekends in college, in high school. And then in college, she got oxycodone. She noticed that it controlled her pain, decreased her anxiety, and also helped her feel normal and peaceful. So that tells you she's at a high risk for developing probably a genetic risk. So she started buying oxycodone from friends, got up to 200 milligrams a day. A year ago, she went to a residential program, but didn't follow up in aftercare and relapsed 6 weeks later. Never been on medications for opioid use disorder. She switched to fentanyl, snorting fentanyl, 10 bags a day. Last use was 4 hours ago. So is she ready for buprenorphine initiation? In the interest of time, I will just say, no, she is not. And it's because she's not in withdrawal yet. So is she a candidate for unobserved home initiation? Sure she is. She's got a home to go to. She, from what we know about her, things are relatively stable. She's cognitively there. She can follow instructions, so she can probably do that. And actually, I can qualify this. Is she ready for me? You could do microdosing with her right away. But if you want to do the traditional method of buprenorphine induction, she's not ready for that yet. Okay, so you say she's physically dependent, so she must be in withdrawal before starting buprenorphine. She discontinues all opioids for 16 hours. After 20 hours, she's having all these symptoms. Is she ready for the initiation now? Sure, now she is. She's in withdrawal. You can start on 2 milligrams of buprenorphine. And so how long does it take for the initial effect? That's going to be about 30 minutes for the initial effect of the buprenorphine. The peak effect is going to be more like 2 or 3 hours after taking the buprenorphine. And so 45 minutes after that initial dose, she doesn't have any change in her withdrawal symptoms, so she takes the rest of the 8 milligram film. So what about additional day one doses? She can continue to take those 2 to 4 increment doses during the first day, up to, I'd say, about 16 milligrams on that first day. So she ends up on 16 milligrams. On day 5, she tells you she's 80% better. Still, she's having cramping in her calves, anxiety, insomnia. So this is probably just some residual withdrawal symptoms. So I would increase her dose at that point. There's lots of different withdrawal symptoms that people can have. It's not necessarily the traditional ones. Anxiety and insomnia is very common withdrawal symptoms. Depression can be a subacute withdrawal symptom. The patient may not even attribute that to the opioids. But a lot of times when you increase the buprenorphine dose, suddenly those symptoms go away. So that tells you that's a subacute withdrawal symptom. They just weren't on a high enough dose. It's most often underdosed rather than overdosed. So, okay, so that's, I think, the end of this section. So I can stop sharing. Were there any questions about this section I can address?
There are, Jonathan.
Sure.
I will go ahead and read them to you. Is there any Michigan law about buprenorphine and benzodiazepines together?
Well, not really. I mean, other than the laws that govern any kind of controlled substance prescription, there's not any special laws about those together. You're certainly going to be under more scrutiny if you are prescribing both of those together. That's a very risky practice to do. But if you're prescribing one and knowing that the patient is getting the other illicitly, as I said, buprenorphine is going to put them at lower risk for overdose. So you're best off doing that if there's not an alternative option of just getting them into residential care.
Thank you. Second question, how quickly does a patient's tolerance lower with buprenorphine? If it is, for example, initiated in the ED, we may not be able to have all of the rules for clinic type conversations at the point of induction. If something falls through at the point of follow-up a few days later, are they still at increased risk for overdose?
Yeah, they'll be at some increased risk for overdose at that point. But it does take a while for that tolerance to develop. So I'd say probably a few weeks. It's hard to tell because with buprenorphine, it's hard to do the controlled experiment with buprenorphine if you're talking about just overdosing on opioids. But I'd say it's probably a few weeks before they develop that tolerance. On balance, though, they're probably going to be better off if they just start that buprenorphine. At least they're protected during that period when they're on it. And it gives them a chance to get involved in treatment. There have been numerous, there's been a few trials of that, of starting buprenorphine in an emergency situation like that. and patients are just better off if they're started in that situation rather than waiting. Yeah.
Okay, thank you. And last question, can buprenorphine be started in a telepsych only practice?
Yes, it can. Under the current rules, you can start that in a telepsych practice. Yeah, they've threatened to go back to the days where you had to see them in person, but that hasn't happened yet. So you can do that tele. Yeah.
Okay, and there's one more question. How long can a patient stay on the medication?
Good question. I think we'll get to that later, but the evidence is that this is a maintenance drug. And so whenever people have tapered off of buprenorphine, whether it's 6 months, whether it's a year, whether it's 2 years, I think is the longest study I've seen, they're at about 90% chance of relapse, as opposed to the 40 to 50% chance when they're on buprenorphine. So that evidence tells me that they have an opioid use disorder, and this is a treatment. It is not a cure for opioid use disorder. It's kind of like insulin for diabetes. If you stop taking your insulin, your blood sugar is going to go up. If you stop taking your buprenorphine, you're probably going to relapse to opioid. So it's a maintenance drug. So we say as long as the person needs it, and they have an opioid use disorder, we don't have a cure for that. So they're probably going to benefit from that for the rest of their life until we find a cure for opioid use disorder. So I actually talk about that with my patient before starting them on it, because it really is a long-term medication.
Thanks so much. And that's it for the questions in the chat. I don't know if there's any more questions for Dr. Morrow. Okay.
I think we're at a break time, right?
We are.
Yeah. Okay. So, and who's doing patient? Is it yeah, so let's come back at what, 10? We can probably come back at 10:20. I ran over a little bit. So 10:20.
Okay. Thank you. So if everyone just wants to take a break, stretch your legs, get a cup of coffee, we will reconvene at 10:20. It's currently 10:06. Thank you. Okay, everybody, we will get started again. It is 10:20. I just want to quickly mention, I did post in the chat a link to our MOC sign up, and I also posted the PDF form of our sign up. Completing this form allows you and any providers that you list on page 3 in your clinic to take advantage of our free same-day patient consultation with an MOC physician. You can reach out with any questions about treating a patient with opioid use disorder or other substance use disorders and providing medications for opioid use disorder, and hear back from our on-call physician that same day. That's available Monday through Friday, 9 to 5 Eastern Standard Time. If you have any questions about the form or the online completion, please reach out. I did leave my email in the chat as well as our administration email. Thanks so much. Welcome back.
All right, thanks, Melissa. Welcome back, everybody. So I am going to screen share again and talk more about sort of management. So Dr. Morrow covered how we're going to get folks started on buprenorphine, and I'm going to talk more about sort of what do you do once you've gotten someone started. Melissa, can you give me a thumbs up? So my slides showing? Okay, great. Okay, fantastic. So what we're going to cover today is sort of follow up in terms of frequency and what are you covering during follow-up visits with patients. A little bit about drug testing, most often through urine, but drug testing in general. Psychosocial support as an addition to medication. Someone asked a question earlier about tapering or discontinuing, so we'll also cover that. When and how to use the prescription drug monitoring program and some limitations with that. And then a little bit about sort of when treatment isn't going exactly as we might hope it is, or when it's not going according to plan. And with time at the end, we will run through a few cases, and my goal is to finish at 11 o'clock. So we will do our best. And again, please pop questions into the chat as they occur to you. First of all, so how frequently do you need to see folks? So Dr. Morrow talked a little bit about sort of during the initiation period and what's the length of that first prescription, but we are often asked what's the right frequency of follow-up, and the frustrating and good answer is there's really no particular standard that you have to follow. This is very much a clinical judgment question. SAMHSA and then Boston Medical Center have different guidelines and what folks recommend. But really it's individualized based on sort of your comprehensive assessment of that patient. And that might be in part related to their substance use, that might be related to also other medical issues that you may or may not be treating. So very much individualized, but I would say sort of a general guideline that I think a lot of us follow is, early on, again, if you're making adjustments frequently, you're changing their dose, they're still feeling withdrawal symptoms, strong cravings, you might be seeing them every week for a little while. And then as soon as they stabilize a bit, maybe they feel like, they're just having cravings occasionally, they're manageable, their opioid use has mostly gone away or feels very controlled, then maybe you're seeing them every 2 weeks, every 4 weeks. And ultimately you can stretch out to, every 2 months, every 3 months if a patient's very stable. You are able to put, refills on. Usually insurance won't let you send in more than 28 days at a time, but you can put refills on that for the very stable patients. So when you are doing follow-up visits, what do you need to cover? This is sort of a wish list, but again, really this is individualized to your patient and your setting, right? There are going to be patients who have the time and you have the time to cover a really comprehensive assessment. Maybe you are lucky enough to have an hour visit with them, but you may only have 15 minutes. And if you're in a primary care setting, you might be doing this plus covering 3 other health topics with them. So really this is individualized, but these are some things that you want to touch on at least over time, even if not every single visit. Most important though for, focus of these visits that you really do want to cover each time early on is basically assessing how is the medication doing, how is it treating the patient, how are they responding. So really at each visit, especially early on, asking them how much medication are they taking. First of all, it may or may not be what you're prescribing to them. Important to ask how they're taking it, like what's their routine? Are they taking it 2 times a day, 3 times a day? Are they forgetting? Some days are they taking more because they forgot how much they took? And as with so many medications where we often find that folks are doing something a little bit differently than maybe we think they're doing. So it can be really insightful to find out how folks are taking their medicine. Are they experiencing any side effects? The ones that we went over again, constipation, urinary hesitancy, nausea, headache, any of those. And again, we can find ways to help them through those symptoms if they are having them. And then how are their cravings and their withdrawal symptoms, right? So Dr. Morrow talked about, we're really titrating our dose to cravings and withdrawal. So how are those? Are they feeling manageable to the patient? And how has their opioid use looked? Have they been able to, if they haven't stopped completely, are they feeling like it's more in control? Are they able to use more safely? Are they using less? Basically, are we getting a clinical response from that buprenorphine? So that information is all going to help you titrate the dose and figure out, are you on the right track with this treatment? So that's kind of, I'd say, number one bucket of questions you want to be asking, even if you can't get through everything else. And then, talking about cravings and triggers, if they are still having cravings, when are those happening? What are the circumstances? Can they identify specific triggers? And that may be time to, if you have a behavioral health team or a peer recovery coach or something, you could engage that person around trying to help your patient manage triggers if you don't have time to dive into it with them. Reviewing safe storage of their medication. So, that's obviously important to do at initiation, but just checking in, do they still have a place if they have kids around, but is the medication stored away from the children? And then beyond that, other really important things, but you may or may not have time at every visit and the patient may or may not want to discuss these other things, but very important, checking in on their mood. This is a really intense time for folks as they're going through a lot of change, right, and trying to decrease their opioid use, and a lot of mood changes can occur in that setting. Sleep is enormous and often really poor quality and early recovery. So helping folks know that it should get better, but also, helping them, whether it's, helping them connect to CBTI, whether it's giving them medication for sleep. If they are a person with pain, how is their pain being managed? Does that feel functional for them? How's their social functioning? How are their relationships? Are they able to go back to work or feel like they could look for work if they've been out? What's their housing situation, legal status, those pieces. And then at every visit, really trying to, well, we'll talk more about, I guess, drug testing, but UVS or for urine drug screening, I'll dive into more, but you may do that at most follow-up visits. And then really assessing the prescription drug monitoring program at each visit before prescribing another controlled substance is really important. So just a word on PDMPs or MAPs as it is here in Michigan. So again, these are statewide tracking systems that show just controlled substance prescriptions, so not all prescriptions. Can be a really helpful clinical tool to understand sort of your patient's patterns of care. Also, patients often don't remember what provider gave them what, or what they were really given, what the dose was. All this information does show up there, so that can be really helpful. Important limitations, though, are that you may not be able to see things that folks are getting from other states. That's really important. And then opioid treatment programs, or also known as methadone clinics, are not showing up here. So if your patient is on methadone, or if they are getting buprenorphine from an OTP, those medications will not show up. So it's important to be aware of that as well. And finally, there is sometimes a lag in the data that's uploaded to the system. So if you just send in a prescription for your patient a week ago, and they picked it up right after that, and now you're seeing them, 6 days later, it still may not show up in the system. So it doesn't mean that it wasn't dispensed, but maybe that bit of time lag. So I mentioned kind of asking folks how they're dosing their medication. So this kind of leads into the question of what is the right dosing. What's wonderful about buprenorphine, again, with its safety profile, it's very forgiving. You can dose it in various ways. It was actually approved as sort of a once a day treatment, and it really is a long acting medication and can be dosed once a day. However, I'd say more commonly, folks are dosing it BID or twice a day. And there are people who will do it 3 times a day or 4 times a day. Sheba will talk more about pain later, but that may be an instance where you dose it more frequently because it is more effective for pain. And so really, it's okay to give your patient some latitude in trying to figure out what works best for them. And what I find personally in my practice is a lot of patients early on may prefer more frequent dosing, and it almost is sort of going along with those behavioral cues. Maybe they used to use their fentanyl 3 or 4 times a day, and so each time of the day early on, it's helpful for them to have that buprenorphine that they can take instead of taking their fentanyl. But then oftentimes as folks stabilize, they may not want to be reminded of the medication so frequently, and they might want to consolidate to once a day or twice a day dosing. So those are all really acceptable and safe ways for folks to dose. So just helpful to find out what people are doing with their dosing. And then, so what about more cravings? So, as we mentioned before, really inhibiting craving, or at least making cravings very manageable, is a big treatment goal, because that's very much associated with decreased use and improved quality of life for our patients. And, important to remember that while our goal with buprenorphine is to really suppress those cravings, buprenorphine may or may not completely take those away. There are patients who will say, yep, I started on medication and I never had another craving. More common, I would say, is that people do still have them, but we want them to be manageable enough that folks can use other coping mechanisms to sort of get through it and not actually resort to use. But if folks are having a lot of ongoing cravings, that's the time to consider a dose adjustment as well. And yes, and cravings really are dynamic. They can vary through the day based on who folks are running into, what stresses they're running across during the day, as well as sort of peaks and troughs of their medication. A little bit more about kind of other monitoring to think about as you're doing follow-up with folks. So Dr. Morrow, discussed, monitoring or checking liver enzymes perhaps before starting. Again, there's really no clear evidence around this. So in my personal practice, again, if I feel like I have other reasons to check labs, I will often monitor some liver enzymes, but it is not a showstopper, and you don't need to do that if your patient does not want to get a blood draw, or you really don't feel like it's going to add anything to the clinical picture. Other important things is just, folks' general health care. If you're able to provide these things in your setting, that's great. But making sure they're up to date on their preventive care, particularly their vaccinations, their screening for and treatment for any infectious diseases, particularly HIV, hepatitis C, and sexually transmitted infections are common in most populations using substances. So offering that screening and referral to treatment if you're not able to treat in that setting. Considering offer PrEP, there's growing evidence that if folks are injecting, that really is an indication for PrEP to prevent HIV transmission. And then checking in with folks about if they have any pregnancy potential, what are their thoughts on pregnancy? Are they interested in birth control, or are they on it? There are a lot of unintended pregnancies in folks with OUD. And we really recommend considering offering long-acting forms of contraception if possible, so things like Nexplanon or IUDs. And one important counseling point for patients is really as they get started and their body stabilizes. In the past, when they've been using substances, they may not have been menstruating, and a lot of times people think they're not able to get pregnant. Oftentimes, as their body stabilizes on buprenorphine and they become healthier, pregnancy becomes more likely, but folks may have had the impression that they are infertile because they've never gotten pregnant before. So just checking in on that often, offering resources as you're able to do that. A few other just kind of practical tips. So if you are offering, when you're prescribing what we say sort of like, a month of medication or a week of medication, try to always prescribe so that the prescription finishes on a weekday. So you aren't having folks run out on weekends and then, on-call providers are getting requests, that kind of thing. So always try to finish the prescription on a weekday. And we really recommend sort of matching your length of your prescription with the time of when you're going to follow up with a patient. So folks are getting their new prescription at each visit. You can prescribe like half films in Michigan, so you can write that on the SIG if you want to say like take 1.5 films every day. That's something that's acceptable because again, those films or tabs can be split. Currently, Michigan Medicaid really will just cover a maximum dose of 24 milligrams. And I have a slide later on dosing, and I'll talk a little bit more about that. But that may change over time, but currently it's 24 total milligrams per day. Without a prior authorization, I should say. And then important to remember, buprenorphine can have sort of an activating effect on some patients. So if they really feel like it's worsening their insomnia, you could suggest sort of taking their medication earlier in the day and not soon before bedtime. And then interestingly, some folks, when they have a dose that's too high, some will feel more fatigued. Some people do feel activated. So it can really go both ways, but if you're noticing those things, maybe your dose is a little bit too high, so we're just checking with the patient and reconsidering that. So let's dive in a little bit more to kind of the question always that comes up around your drug testing or toxicology. So this really, it can be a helpful tool for both clinicians and patients, but it also can be a fraught experience for patients. I think a lot of us know patients who've had probably really difficult experiences, leaving your urine drug test, whether that was in the criminal justice setting or the clinical setting, and feeling like they're treated differently based on that, or maybe they are sent away from care because of that. So just important to know that history and that background for what most patients have experienced. But on the clinician side, what can be so helpful is, this really can help you assess your patient's response to buprenorphine. Are you seeing ongoing opioid use, or are you seeing the opioids go away? And that can really help you. Also, other substances you're seeing in there can help you just guide a conversation about your patient's health overall. You can share safer use strategies, harm reduction strategies, if they are having ongoing substance use as well. And from the patient standpoint, it can really be educational, right? As our drug supply is becoming more and more unpredictable and more contaminated, patients really are often surprised by what's showing up in their drug testing. And so that can be an important, empowering piece of education for them as well. So yes, I think those are kind of the main things, and I like the last point on this slide, which is really, this is a test that we are doing for the patient to help the patient, not something we're doing to the patient. So I think just kind of keeping that frame in mind will help frame your conversations. When you're talking to patients about drug testing, these are just a few suggested lines that you might use, and you'll kind of come up with what feels comfortable for you and your patients. But some ideas you might say, as part of your treatment, I do request urine drug testing. This measures lots of different medications and substances that might either interfere with your treatment or impair your treatment in some way. Or you might say, what I'm looking for with this testing is really the presence of what I'm prescribing that is there in your body, which is the buprenorphine, and everything else just gives us more information to talk and help keep you safe and healthy. You can just let folks know that you request drug testing on all patients prescribed these medications so that they don't think they're being singled out for some particular reason. And then you can let them know, if we see something unexpected in your test, we'll talk about it together. We'll work together to address it. I'm not going to discharge you from care based on a urine drug testing result. So those are some of the ways that you can just talk a little bit more about that. There is, there's really not, again, very clear guidelines about how frequently that you should be testing. So this is, again, can be in your clinical judgment. SAMHSA recommends sort of periodic random testing. ASAM, American Society of Addiction Medicine, really says, you know, you're going to determine the frequency based on a whole number of factors, some about the treatment setting, some about the patient themselves and the treatment they're receiving. I think what a lot of us tend to do, and just a place I might recommend starting, is just, you know, doing it at the initial evaluation when you start the medication, and then just ideally aiming for each time you see the patient. And in my own practice, what I do is, you know, we offer it at every different visit that somebody presents to care. And I let them know, you know, if there's a time where you can't leave one, that's okay. You know, we've already checked it a lot of other times. So just do your best to leave one whenever you show up. So that's kind of one way of approaching it. But again, you can tailor it to your treatment setting. Urine is the preferred way of testing due to it's just, you know, the easiest way to obtain the sample. It's low cost and is generally a helpful test. So that, and also what patients tend to expect for the most part. And then a little bit more just about telehealth, since this is, you know, is definitely a part of our life now, which is wonderful and has expanded access for opioid use disorder a lot. Again, the optimal frequency of testing is not known, and it's really, you know, it's not clear if that decrease in drug testing during outpatient treatment will actually change any patient outcomes. So overall, you know, the picture is, you know, take the whole clinical picture into consideration, and, you know, urine drug testing can be one part of the tool. I will just be brief on kind of this interpretation slide, but you can always look this up if you're not sure what is showing up and what it means if something is positive, but different opioids are metabolized in different ways, so they show up differently in urine drug testing. What I think is most important to know about this is that a lot of the semi-synthetic opioids and the synthetic opioids, such as fentanyl, most importantly, are not going to just show up on your standard positive opioid drug screen. So when you're counseling patients and when you're interpreting these, you know, just really important to be able to go back and think what could actually be causing those positives, and what might you be missing also. This is a little bit more about windows of detection. Nothing that you need to memorize here. You can easily Google and find a chart like this or refer back to these slides. But again, there are, you know, different detection lengths of time for different tests and for different substances, and honestly for the amount that someone is using. So if someone's using every single day, it's going to be a longer window of detection, whereas if someone just uses one single time, it may disappear sooner. So just keeping that in mind as you're interpreting your testing. There are lots of false positives and false negatives, so that's another important piece to keep in mind when you're interpreting. This is a list of just some of them. But just to call out, especially, you know, lots of false positives for benzodiazepines and for amphetamines and methamphetamines. And I'll talk in a moment about confirmatory testing, but just to know if these show positive and it really doesn't fit with the clinical picture, or the patient is confused at why they're positive for something, you may be seeing a false positive. So if you need to, and we'll talk about the times to order this, but there is what we call kind of confirmatory testing, right? This is gas or liquid chromatography, mass spectrometry, which is always hard to say. This is a much more costly test, but it is much more accurate. So if you feel like you really need to know if your point of care test is correct or incorrect, this is the test to turn to. There are quantitative ones available. Just important to know about the quantitative. The levels really do not indicate, they're not reflective of the amount of the substance taken. So don't interpret them that way. More interpret them as sort of like present or not present, but not in more detail than that. And then what do you do with unexpected results, which happen often now, especially with the drug supply as it is. So I think, you know, most important thing really is that you want to use this as a tool, again, for the patient, a way to improve the patient's treatment and improve your therapeutic alliance with that patient. So what might you do? You can just ask yourself, how can I use this to improve the therapeutic relationship with my patient, and take it from there. So in that vein, you can first of all just express curiosity, like look at the result with the patient and ask them if they're surprised or what they make of it, or what they think that positive result might be about. And again, many patients will be surprised because of the current drug supply, and they might say, oh my gosh, I had no idea like fentanyl or benzodiazepines were showing up in the methamphetamine that I have been getting. So I'm really glad to know that. And you can also use it as a conversation starter about their patient's goals. Again, you can talk to them about, they express that they really wanted to be free of all substances. And this is what the testing is showing. What do they think about that? Where do they want to take that? And again, if you think that a confirmatory result would really change your management or change something for the patient, you can absolutely order that confirmatory testing. Just keeping in mind, again, it is expensive. And if you don't think it really will change your management, encourage you to save those healthcare resources. Most importantly, again, don't ruin your relationship over a single test, and really, use that test result and incorporate it into your entire clinical decision making and the whole picture of the patient and how they're doing. So a little bit about follow-up visits, monitoring, and drug testing. Let's talk a little bit more about psychosocial treatment, which does always come up and can be an important part of treatment as well. This comes in many different forms, including what's listed here: mutual support groups, individual therapy, group therapy, various forms of counseling. Also important to remember that, a patient might be getting psychosocial support from informal networks, right? Supportive family, supportive friends. So it does not necessarily have to be one of these structured environments that gets them the support that they need. But what about the formal counseling and therapy? Do we need to do that? Do we need to refer to that? So there have been multiple randomized controlled trials, again, that actually do show that adding behavioral therapy really doesn't significantly improve the outcomes achieved by buprenorphine or medical management with MOUD. So certainly, we encourage, if you can, offering connection to psychosocial support. Absolutely, the patients should not be denied any medication if they decline that kind of support. And you can check in with patients frequently over time about whether they're interested in engaging in some kind of support, and that may change over time as their brain stabilizes on their medication. They may become more interested in that kind of support. And then this is just kind of in that same vein. Actually, the FDA and SAMHSA put out a joint letter very recently, stating just very clearly that oftentimes there's a barrier that's cited by providers that they can't provide buprenorphine because they don't have the ability to help patients engage in counseling or their psychosocial services, and that this is really their clarification that buprenorphine treatment should never be contingent upon engaging in psychosocial treatments. So then also someone asked earlier about how long do we treat patients with buprenorphine? And I think Dr. Morrow already cited some of this evidence, but again, we don't really know the optimal length of addiction treatment, but mostly what we think is the longer the duration, the better the outcomes, because of that pretty high risk of relapse if people do discontinue their buprenorphine. This is just kind of reiterating what SAMHSA says, and the best result for them really occurs if a patient receives the medication for as long as it provides a benefit, which really for most folks is very chronically or perhaps lifelong. Yeah, so I did want to talk about actual discontinuation again. So Dr. Morrow already referenced, we think about up to 90% of patients will stop, or when they stop buprenorphine, that they will return to opioid use. So very, very high rates of recurrence of use. And so what evidence we do have really supports that outcomes are better with longer retention and treatment. And then there is a little bit of evidence that, a very slow taper, if you're going to taper, has the best outcomes, but there really also isn't clear guidance around how to taper if you do decide to taper with a patient. So, really what I recommend, if patients are asking about tapers or discontinuation, which absolutely will happen, It's really having a conversation again about curiosity, sort of what's leading them to want to taper. Sometimes it's a side effect that somebody doesn't like, but oftentimes it is related to stigma. I find, someone in their NA group has told them they're not really in recovery if they're on a medication, or their family thinks they're not really in recovery if they're on medication. Sometimes it's a housing limitation. We have folks who are trying to get into different types of supported housing or transitional housing, and they're not able to be on buprenorphine in that setting. So that might be the reason. Maybe they're not finding it effective because they don't have the right dose. So just kind of trying to dive into a little bit more about the reasons that they are wanting to discontinue. And then if they really do want to stop, have a conversation about what's their safety plan for if they stop. What do they think is going to help them avoid relapse? What's different now than previously? That's going to help them stay safe. And then if you do decide to taper, really just making a flexible, individualized plan, and have frequent follow-up as you do this. I have had patients who, they really want to taper and they want to do it rapidly. So we do it over the course of several weeks, which is very difficult for people, but some people can do that. I've also had patients do it over the course of 2 years where they're very, very slowly going down. So really just individualizing to what's going to keep the patient stable, but also help them meet their goals. I think I kind of covered all this already, but and then one last point from this slide is just if you do discontinue or taper a patient, have a plan to follow up with them several times again once you're completely through that taper, just to see how they're doing and let them know that they always have the option to restart if the taper didn't work out or they realize that it's too destabilizing for them. So kind of just stepping back, what is all of this, the initiation, the stopping opioid use, what does this all look like in terms of time? Again, very individualized based on the patient, but this gives you a general sense, sort of the initiation phase that we think of sort of, the initial brain stabilization, withdrawal symptoms going away, cravings generally being managed. For some folks, that happens over the course of a day, a couple of days, or a week. I'd say more commonly, we see that over the course of several weeks, that people will really start to feel stable and pretty normal on their medication. And so counseling patients so that, just because you don't feel perfect right away, it doesn't mean that you're not going to get to feeling more normal. And then, in terms of when people stop using opioids, again, not every single person not everybody's goal to completely stop using. Might be to use more safely or to use less. But most people who do want to stop completely, we see that happen on the course of sort of weeks to months into treatment. And then the cessation of other substance use, this may or may not happen, and it may or may not be a goal for people. And unfortunately, buprenorphine doesn't treat any other substance use disorder besides opioids. But a lot of people are looking to decrease their other substance use, and we tend to see that happen sort of more on the order of months to years into treatment. And then stabilization of the other components of their life, right? Their relationships healing, getting jobs, getting stable housing, less involvement in the criminal legal system, that sort of thing can take a little bit longer. And so I think as you're working on this with patients, trying to always step back with patients and look at the overall trajectory, and there may be sort of bumps and ups and downs in the short term, but sort of like thinking about this overall trajectory and helping reflect that back to patients. If they feel like they're frustrated that things haven't changed fast enough for them. And just always like this quote, just because you've gotten the monkey off your back doesn't mean the circus has left town. So really, after today, you're going to have this amazing, powerful tool to help patients really change their lives by prescribing buprenorphine. But there are definitely going to be times when treatment doesn't progress quite as you plan, or that things don't change in patients' lives quite as fast as they want them to, or as we want them to. So I'm just going to spend a couple minutes going over some of those other issues that may come up during treatment. One is the recurrence of substance use disorder, particularly recurrence of opioid use disorder, right? Or we might call it relapse. So this is usually in response to some kind of stressors or some kind of stimuli that trigger the person to use again. Precipitants for this can vary, but oftentimes, some sort of negative affect. A lot of people report boredom as one thing. If they're not engaged in anything that feels meaningful or structured, that can be a trigger. Conflict, feeling angry, feeling upset. Often for people going to certain places or running into certain people will be very triggering. or other kinds of social pressures, stresses at work, that kind of thing. So those can all be different precipitants. And really important when this happens is, a recurrence can really be an amazing growth point for a patient. So, if they report that they have had a relapse, first of all, thank them for sharing that with you. And the fact that they share it means you have a good therapeutic alliance with them. And then engage them in discussion around kind of what happened, what made them vulnerable to using. Was there a specific trigger? Were they really stressed? So they just didn't have any kind of emotional bandwidth to deal with whatever stimuli came along. Are there resources that you can offer to help them, so that the next time they come into that situation, they won't have the same outcome. You can also really just, I would say, normalize for patients that it's very common that people experience relapses, and it does not mean that they're starting over in their treatment and that they're back to square one. That this is something that we see, and it doesn't mean they have to completely destabilize with one relapse. And remember that shame, disappointment, and guilt is all really a part of that when patients relapse, especially as they're telling you and they're sharing, they may feel like they're disappointing you in the treatment. So remember that those are all pieces, and sometimes that shame and guilt actually can spiral into more substance use. So being able to normalize it and help sort of follow that shame and the guilt can help them sort of stop the process from becoming a worse recurrence or relapse. And then, last thing for, in the setting of a recurrence, also just, reassess how you feel like the buprenorphine is doing. Maybe the dose is too low. If they're having a lot of cravings and that's what led them to relapse, you might consider increasing the dose. And again, you can always consider, a higher level of care if that's available to you, if you really think that the patient needs more than what you're able to offer them. Maybe if they're having ongoing recurrences really frequently, despite a maximum buprenorphine dose, and you don't feel like there's much else you can offer them, you might consider connecting them to a higher level of care if that's an option in your community. Ongoing cravings, which we have referenced multiple times. So the FDA really advises only up to 16 milligrams, but this guidance has not been updated in a while, particularly in the setting of high potency synthetic opioids like fentanyl. So really clinically what many of us are doing at this point is, up to 24 milligrams or even up to 32 milligrams. Mentioned in Michigan, that's a hard thing to do from an insurance standpoint, but multiple other states do allow escalation to 32 milligrams fairly easily. And there is growing evidence from the physician clinical support system, and actually ASAM just put out their new clinical considerations, really saying that we need to consider doses up to 24 or 32 milligrams, or some places recommend even higher, especially during the stabilization period. And then on the right is just some of the evidence. There's growing evidence out there that higher doses really can be correlated with better retention and care. And this graph here in this image is just sort of showing data from an opioid treatment program. Both methadone and buprenorphine are the two different lines, but basically both show sort of the higher dose that you go, the more retention and care that we see. So really kind of shifting again, sort of those earlier thoughts on dosing limits and liberalizing prescribing, again, knowing that it is generally such a safe medication. Polysubstance use, which we have talked about already, but just kind of reiterating at this point is very much the rule and not the exception, whether that's because patients are choosing to use multiple substances, but often just because the drug supply is so contaminated that people are accidentally using lots of substances. And in lots of our overdose deaths that we see, we're seeing multiple substances found in those. It's usually not just one. So important to also remember that in terms of our counseling with patients, first of all, that remembering that buprenorphine does not treat other substance use, unfortunately. And what I often see anecdotally, even early on, as patients are stabilizing on buprenorphine, decreasing their opioid use, we may actually see other substance use increase for a while. Again, because we're sort of taking away one of a patient's typical coping mechanisms. And until they can develop other coping mechanisms and meaningful activities in their life, other substances may fill that void. So it's not uncommon to see sort of a spike in polysubstance use early on in treatment that then improves over time. And, when you're talking with patients, just, ask them if they'd like to talk about their other substance use, and you can you remind them that their buprenorphine treatment is sort of separate from that. You're not going to discontinue their buprenorphine because of other substances being used, but you want to be available to help them address that use if they want to. And then it can also just be, another good moment to have counseling around the risk of combining substances. We certainly see that sometimes overdose risk gets worse because people will sort of, if people are using, for instance, an opioid and a stimulant, people will sometimes think that they can treat an opioid overdose with a stimulant because it feels like it has the opposite effect. So they'll use a high dose of an opioid and then a high dose of a stimulant and then have a very complicated overdose picture. So just kind of counseling patients about those risks of polysubstance use, making sure they're connected to safer use, like whether it's syringe service programs or other educational resources around that. And then also kind of at the end here, wanted to just address pill counts, which we get asked about often. And this sort of relates to some concerns about medication sharing, or also gets called diversion. We often get asked if people can still prescribe buprenorphine, even if they don't in their setting have the capacity to do pill counts. And the answer is absolutely 100% yes, you still can. Pill counts, especially early on, were sort of promoted as a great way to prevent diversion or medication sharing. And it is an option, but I would say not a very common option used anymore. There are a lot of other sort of less intensive and more patient-centered ways to either intensify treatment if someone's not doing well, or to address concerns about medication sharing if you have them. Some of those other options that you might have is you could have the patient follow up more frequently, have them maybe come for more urine drug tests if that might add some structure for them. Again, engaging behavioral health if they're willing to do that, or intensifying treatment in other ways. So absolutely no need to do pill counts if it works for you in your setting. It is still an option, but not by any means a necessity or something you need to pursue. So the very last part, if I have, I'm going to assess my time. Okay, I have 1 minute till 11, so I'll just kind of briefly go through these cases. Sorry, we won't probably discuss them as a group right now, given our time limitations. So I apologize for that. But just 2 examples. So this is Katie, who is a 35-year-old woman, and she has diagnoses of severe opioid use disorder and moderate cocaine use disorder. She's been treated with buprenorphine 16 milligrams for the past 6 months, and she's completely stopped using her heroin, and that's been confirmed by urine drug testing as well. However, her urine drug test continues to show ongoing cocaine use. So questions are sort of, how might you respond to that cocaine use? And does the use of a particular substance really affect your treatment plan? And so I think key take homes I would say here is just, how do you respond to that cocaine use? It's really, in my mind, asking, permission to ask her more about it. Is it something that she's wanting to address as part of her treatment plan with you? Or is it not something that she wants to right now, and maybe engaging in some motivational interviewing around that? And then in terms of the nature of the substance, how does it affect your treatment plan? So, no direct interaction between stimulants and buprenorphine. But as Dr. Morrow went over, the combination of benzodiazepines or other sedatives plus buprenorphine might affect your treatment plan. And again, that doesn't mean discontinuing buprenorphine, but to me, what that means is just assessing again with the patient, like, are they having any side effects? Are they getting sedated because of that combination? And reviewing, making sure that they understand that risk benefit as well if they're going to continue with their buprenorphine. And then second case is Kevin, a 31-year-old male who has chronic hepatitis C and OUD, and comes for hepatitis C treatment. He's been on buprenorphine for about 8 months and lived with his wife and his 10-month-old daughter. And he says he's been getting his Suboxone from a cash-only provider who lives really far from his house and got another job to pay for those visits and a prescription. That provider hasn't ever checked any labs on him. But he was diagnosed with hepatitis C when he was in jail a few years ago. And he says it's so much easier to keep doing heroin than to get treatment. And that is a common thing that we have heard from folks. And now that you all are going to become prescribers, hopefully that's helping us tackle that problem. But historically, it is much harder for people to get treatment than to either become incarcerated or continue using their substance. So kind of just thinking about Kevin over the course of a year, he is still working, he's providing for his wife and his daughter. He does call at some point and ask about an early refill because his prescription got stolen. And he comes in and his drug screen is positive for buprenorphine. So he's been taking that, but also some cocaine. He does, when you chat with him a little bit further and ask him sort of, about his medication, he does say that he's been having back pain. So he did take an extra dose of his medication for a few days and thus ran out early, actually, instead of having his medication stolen. And so you sort of, engage in the conversation, curiosity with him, trying to understand about running out early, and normalize that occasionally it happens that patients may take a little bit of extra, and to please, let you know the next time so that you can help troubleshoot, so that he doesn't run out early, and so that you can provide him appropriate treatment. So anyway, he expresses gratitude to you to be able to continue treatment and have this conversation. And so hopefully you will be able to have some of those experiences of people having some successful treatment and success in their life. So with that, I am going to stop because I have talked a lot, and I'm going to see, or Melissa, perhaps you can share from the chat any key things I should address. I know I ran a couple minutes over, so.
Yes, I'll do that. Thanks, Liza. We have a question from Dr. Olaf. Sorry if I'm mispronouncing names, forgive me. One big challenge we have experienced with prescribing controlled substances is the cost of a urine drug screen. Any pointers on that?
Oh, great question. Gosh, I actually, this is crazy, but I don't actually know what the cost of it is. I think our clinic gets them very cheaply, for just the point of care testing. I'm wondering, are you referring to the point of care testing or more the confirmatory send outs? And if anyone else knows how much the urine drug test actually costs or has run into that problem, I totally would appreciate anyone else chiming in because I haven't run into that yet.
So we were using both our local hospital lab and our and Quest, and it was, I think part of the issue was we had it as if the initial screening test is positive, reflex to confirmatory testing, and then we were getting patients who were getting bills in the multiple hundreds of dollars to, I think I had a patient who had a $1,300 bill for a urine test, and we started getting a ton of pushback, and so we didn't have point of care testing in our office. So I think that's probably our first take home, is looking into what options we have for point of care testing. So.
Yes. Okay. Yep. That explains it. So yes, anytime those confirmatories get sent, and if you do have a reflex system, those are absolutely going to incur quite a few costs. So definitely, if you're able to change in your system, first of all, not having a reflex at least, unless you specifically order it and decide that it makes clinical sense to order that. And then, yes, if you're able to do point of care testing, I should say that is, I think the main way that our clinic handles it is, the medical assistants are just doing the urine dips and reading them for us. So if that is an option for you, then it doesn't become a whole additional charge for the patient.
And if I may add,
And I'll just add that they have point of care tests now that include buprenorphine and fentanyl, so you can get those now for.
Okay, next question is from Dr. Mather. Regarding urine drug screen testing, given the large coincidence of comorbid mental health conditions and significant risk of false positives on common treatments, i.e. bupropion and sertraline, and cost prohibitive nature of confirmatory testing, is it reasonable to forego urine drug screen testing for patients on these potentially confounding medications altogether, perhaps after initial testing / confirmatory testing while on buprenorphine therapy, as the findings would be unreliable? Or is there another approach to helping monitor this information?
Excellent question. And yes, so common, right? That our patients are on a number of those medications. So this is, again, not guideline based, but my personal feeling, and others can please chime in, is sort of how I handle that is I do still do the testing. But again, I have that in my mind that they are on all those other medications that may be causing false positives. And then again, I'll talk with the patient like, hey, you showed positive for benzodiazepines. That could be because of all these other things, but do you think you may have used any? And sometimes patients will be like, oh yeah, I did. I was really anxious and I took a Xanax from my friend. And that may be your answer. So I think it can still give you information, right? And then you can have that conversation of like, okay, well, next time, instead of getting it from your friend, here's how we might deal with it. So I think that's just an example that I think it can still add information, even if there may be false positives. And then what I will sometimes do, particularly with benzodiazepines, because I do care a bit more of about the safety of that. If it pops positive for folks a number of times and they, are not disclosing any use and they feel confused or dismayed by it, I will send it off one time for a confirmation. And then just make a note in the problem list of my chart, or somewhere else to go back and see it and say, all right, I've already done a confirmatory, it was negative. When benzodiazepines show positive, it's probably due to this other substance or this other medication. So that's how I tend to handle it. I'm happy to hear if others handle that in a different way.
Okay, and last question. Is there a role for buprenorphine naloxone for prescribing protocols for chronic pain, i.e. the prescriber wants to discontinue, but the patient is highly habituated or resistant, i.e. prescriber feels they are addicted, but patient will not acknowledge that because it is a prescribed, quote, medication?
Oh, yes,
It-
great question. And that is a whole presentation all into itself. Sheba is going to touch a little bit on prescribing for chronic pain, so I may hold that question, but I think there are sort of two questions embedded in there. And one is the whole conversation with the patient and perhaps diagnosing them with a concurrent opioid use disorder or like a complex persistent dependence, and sort of how to have that conversation with a patient. And then there's the actual kind of medical part of the deprescribing. And those can sort of be broken apart, but I'm going to let Sheba do her talk on the chronic pain portion and hope we can answer some of those questions, and we're happy to follow up otherwise as well. All right, and I will, I think Dr. Morrow is up again.
Yes, okay, so let me share this one. So I'm going to talk, I'll try to go through this quickly so that Shiva has enough time for her pain, but talk about stigma, which is very important with the topic with substance use disorders and certainly with opioid use disorder. So first of all, I'll be using the term MOUD, medications for opioid use disorder. That's a recommended change from ASAM over the medication-assisted treatment. So MOUD, that's what I'm talking about. It's medication for opioid use disorder. And we'll start out just addressing some common myths about MOUD. One is that buprenorphine, methadone, you're just trading one addiction for another. But the reality is that these treatments bridge the biological and behavioral components of addiction. And research has shown that a combination of medications and behavioral therapies can successfully treat SUDs. I mean, the point of these medications is that all those criteria that we list for a use disorder, all of those resolve on buprenorphine or methadone. You're not spending excessive amounts of time. You're not neglecting other areas of your life that are important. Your functioning improves. That shows that you're getting better. There's not a meaningful way in which you're having addiction symptoms at that point if you're really stabilized on these medications. So that's medically, that is a treatment. Very different from just having another addiction.
Jonathan, sorry to interrupt. Your slides are a bit off center for me. Is anyone else experiencing that, or can everyone see the full screen?
Okay.
They look okay here.
Okay. Just me.
All right, I'll just keep, yeah. So and I'll point out that we don't seem to have the same sorts of thoughts about other very equivalent treatments for nicotine use disorder. We have nicotine gum, nicotine patches. That's exactly the same approach as using methadone. Chantix that's a partial agonist. That's exactly the same approach as buprenorphine, but we don't seem to have the same thoughts about about that as trading one addiction for another. Is clearly you're getting the addiction under control when you're using these substances. Another myth is about diversion. A lot of people are very concerned about diversion of buprenorphine, and it is misused. You can see it's what is it? Where's buprenorphine? 27.8% in this study of buprenorphine prescription users had misused buprenorphine at some point. So there certainly is some misuse potential. But what does that mean? So misuse means taking a medication in a manner, by a route, by a dose, in a way other than is prescribed. So that happens with basically all medications, antibiotics. People do that with all kinds of medications, including buprenorphine. But it's important to ask why people are misusing buprenorphine. What are the circumstances in which they're doing that? So buprenorphine can cause euphoria, especially in non-opioid dependent people. It is an opioid, so it can cause that kind of reaction in people. It's less likely to do that because it's a partial agonist, but it does have that effect. But as I said, the misuse potential of buprenorphine is less than you have with full opioid agonists. There's a fairly substantial proportion of people who use buprenorphine who will misuse it. That has more to do with the people who are prescribed buprenorphine. These are people who already have a history of misusing opioids. But the drug itself is actually less likely to be misused than full opioid agonists. We use a combination product, buprenorphine plus naloxone, that at least theoretically is less likely to be misused than the monoproduct. Although I'll say it's not really clear that it's that much better than the monoproduct at preventing a misuse like that. But that's why we prescribe this combination product. But the most important point I'd like to make here is that most of this illicit or misuse is to prevent or treat withdrawals and cravings. And in fact, when you look at the reasons people have misused, when you ask them why were they misusing the buprenorphine, what was the point of that, very few, it's like 3 or 4% are saying that it's because they wanted to get high or this was my drug of choice. The vast majority of that misuse is basically self-treating their addiction to opioids. It's the same reason that we prescribe the buprenorphine. So it's probably there's some kind of barrier to treatment with buprenorphine that they're meeting by getting this illicitly. So that's what most of the use is, and that's reflected in the statistics of people of treatment. People worry about causing an addiction or promoting an addiction by providing buprenorphine. This is data from a 2019 study of all the treatment admissions for drug use. There were 1.5 million treatment admissions for drug use in 2019. 13 of those were for buprenorphine. Not 13%, 13 people in 2019 were treated for buprenorphine addiction. So it's not a major problem. It's not impossible to get addicted to buprenorphine, but it's just not happening. So it's really not as big a concern as I think a lot of people make it out to be. All right, but I said I'm going to go quickly. So there's a thought that MOD is associated with opioid-related overdose. The fact is it's associated with a reduced risk of opioid-related overdose. And it's important to know that if somebody detoxifies from opioids, they go through withdrawal, they're losing tolerance very quickly, and even one use of opioids in that situation can result in a fatal overdose. So in any situation like that where someone is is using and going through withdrawal and discontinuing repeatedly, which people are doing all the time when they're addicted to opioids. They're going to be much safer if they're on a long-acting, controlled opioid like buprenorphine or methadone or something like that, where you're not going to have these ups and downs in their opioid use. Okay, so how can we address stigma? So first of all, so stigma means a mark of humiliation or a lack of respect. And if you're stigmatizing, that means you are encouraging a feeling of humiliation and expressing a lack of respect for someone. That's not something you want to be doing, obviously, for somebody who's in your care, who's a patient of yours. That's the opposite of what you want to be doing with them. And our patients, substance abuse patients, they face stigma from multiple different arenas. So they face stigma from the public in general, lots of stereotypes about people with opioid use disorders. They're dangerous, they have moral failings. It's a choice rather than a disease, things like that. And it deters the public from paying for treatments that are evidence-based, allowing insurers to restrict coverage for substance use disorders. It has real implications for their treatment. People also, our patients are also part of the general public, so they'll internalize that stigma and blame themselves for their substance use disorder. That'll lead to them to engage in all kinds of maladaptive behaviors, not going into treatment and getting help, all kinds of negative feelings about themselves that lead them to disengage with care or disengage from their own relationships. They'll face stigma from the recovery community as well. And some of that stigma is around the medications for buprenorphine, seeing people as not being in abstinence or not really in recovery if they're on these medications. It also contributes to a lack of residential care or transitional housing for people who are receiving medications for opioid treatment disorder. And then you also get stigma from clinical providers. Things like belief that the treatment is ineffective, and it can lead to inadequate pain management, lack of caring conversation, relationship building with patients, premature discharge, neglect of patients with substance use disorders. And that's really a major problem. In fact, healthcare professionals are the most commonly cited source of stigma for patients with substance use disorders. That's the opposite of what it should be. And in fact, it's usually the people who are providing treatment for their substance use disorder. That's the most common, that's where they're finding the most stigma. And this is the most stigmatized physical or mental illness, is substance use disorder. It tends to be worst among the more seasoned clinicians, who have lots of different stereotypes about substance use patients. And that leads to lower empathy, lower provider involvement, shorter visits, lower patient engagement and retention. So it's really a problem that's important to address in your own practice. So one thing that you can do to address that, and there's been studies on this, is using language of dignity and respect. And so an example of this is referring to patients as a person with a substance use disorder, a person with an opioid use disorder, as opposed to defining the person in terms of their illness, or using some obviously pejorative term like a junkie or something like that to refer to your patient. Also, with drug screens, for example, clean, dirty, these are words that have obvious kind of moral implications. Much more neutral is positive or negative, or even better, expected versus unexpected results. And there's other examples of that. it's also important, like harm reduction strategies are often hampered by stigma. But this is something that we should really be engaging in, just like we do with other illnesses. So the point is to reduce the harm associated with their illness. And so some of the things that we can do that is there's access to sterile injection equipment, giving naloxone to prevent overdose. These are absolutely things that we should be engaging in with patients. And it's helpful to compare substance use disorder with other chronic illnesses, because that's what it is. It's a chronic relapsing illness. It has a heritable component. It's influenced by environment as well as behavior. It responds to appropriate treatment, but without adequate treatment, it's progressive. You can get a lot of morbidity and mortality. It has a biological and physical basis, and it requires ongoing long-term care. That, yes, you'll get recurrences as part of that, like any other chronic illness that we face, like diabetes. So if you think about diabetes, if you have patients with diabetes, what would you do if you had a patient who didn't take their medications, didn't adhere to their diets, didn't get their labs done, didn't go to the nutritionist or diabetes education classes? Would you tell them it's their fault that they have uncontrolled diabetes, that they're making because of their choices that they're sick? Would you deny them medication or medical visits until they go to the nutritionist? Withhold their medication if they run out early? Kick them out of your office if they have hyperglycemia? Just think about that, and why would that be acceptable with addiction rather than diabetes? So how can we counter stigma? A few strategies here, just generally speaking. Be open to new research, new ways of thinking. Be open to changing. A lot of times the new research will challenge your ways of thinking, the ways you've done things. I've changed my practice many times. I cringe at some of the things I did when I first started treating people, but just be open to that and learning and changing as new evidence comes out. When you see stigma, discrimination, speak out. Use your power, use your position to challenge that. Watch your own language, your own behaviors, and just always remember to treat people with dignity and respect. Just try to keep that at the forefront. Treat people with respect and dignity, and provide people with access to evidence-based treatments. Okay, but I should stop, and if there's questions, I'm happy to address that, and then we'll turn this over to Dr. Simon.
I don't see any questions in the chat. Any questions for Dr. Morrow? Okay. Turn it over to you, Shiva.
Thank you. How do my slides look? Do they look okay?
They look good.
Thank you. Okay. All right. Well, I'm going to talk to you now about pain management. Obviously, this is a very large section to cover in a short amount of time. So I tried to break it up into thinking about acute, chronic, and perioperative pain management, mostly for our patients with opioid use disorder, but also thinking about our patients who have a physical dependence on opioids because they've been prescribed opioids for a long time, usually. So let's get started. So we know from studies that patients with opioid use disorder who are on opioid agonist treatment, and opioid agonist treatment is buprenorphine or methadone, have less pain tolerance than matched controls. And so the studies were done using peer groups, people in remission, or matched people against siblings without an addiction history. And so why is this? we're not totally sure. We think probably there's an increased pain sensitivity and some opioid cross tolerance. And so when you have a patient who is on buprenorphine and they get into an accident, or they, have a procedure planned or unplanned, or they have a dental extraction, some sort of acute pain management need, they are going to need to take their daily dose of buprenorphine before they get any analgesic effect from other opioids. And so what does that mean? If you have a patient on 16 milligrams of buprenorphine naloxone daily, and they get 5 teeth pulled out of their head, they're not going to get any pain relief from taking their 16 milligrams of buprenorphine. That's just sort of their daily opioid dose. We're going to need to dose additional buprenorphine or additional opioids on top of their daily dose before they have any analgesic effect from opioids. And obviously in that setting, we would maximize a non-opioid pharmacologic treatments as well. So, anything we can prescribe that is not an opioid that could help treat their pain, we really try and maximize those medications as well. Okay, and so again, a general approach to treating acute pain for patients on buprenorphine or methadone is, start by using any non-opioid analgesics or non-pharmacologic management in general. So these are things like Tylenol, or acetaminophen, any NSAID, referring patient for things like physical therapy or epidurals. You can use the SNRI duloxetine, amitriptyline or nortriptyline. These type of medications, you want to make sure that you're using all of those types of medications first. But unfortunately, there are conditions where it is appropriate to prescribe an opioid. And if you are in that setting, or if that case does arise, I usually try and dose about 1.5 times the usual amount prescribed for the condition, as well as continuing their baseline dose of buprenorphine. And we will go over that in a minute when we get to our perioperative management. If you have a patient who takes their dose twice a day, they're on that 16 milligrams of buprenorphine naloxone, and they take it twice a day, they might get some benefit from splitting it to TID or QID dosing. So you could have the patient that takes it, their 16-4 milligrams of buprenorphine, take it, 4 times a day instead. Some patients do not like that though, and they will say, no, I want to stick with taking it twice a day, and that's fine, just something to suggest. And then a tip for outpatient management. If you have a patient who, I don't know, sprains their ankle or has some sort of more minor but still very painful condition, you could also consider increasing their buprenorphine dose if they're not on the maximum dose covered by insurance, which is typically 24 milligrams of buprenorphine a day. So consider increasing their buprenorphine dose by up to 25% for a week. Put them on 3 or 4 times a day, TID or QID dosing, and then reassess them. I like to try and reassess them in a week, even with a telehealth appointment. Yeah, I have a patient who had a Crohn's flare a few weeks ago, and we increased her buprenorphine dose. She usually takes 2 milligrams 4 times a day, and I think I gave her an extra 2 milligrams, and she reported that was I gave her an extra 2 milligrams a day for a week, and she reported that really significantly helped her, especially with sleep. So this is something I think that's easy to do in an outpatient setting without having to prescribe a full opioid agonist. Where am I on time? Okay, I'm doing okay. Any questions about acute pain management? I know it's very brief, so you can always contact us if you have any questions. What about peri-procedural management for patients taking buprenorphine? I think in the past there was some there wasn't really an expert consensus on whether or not buprenorphine should be discontinued before procedures. But I think the expert consensus now is firmly planted on the side of not discontinuing buprenorphine before the procedure. It can be very difficult to restart the patient's buprenorphine after the procedure, and many patients just don't do well, especially when they've been on it long term when we discontinue it. So really, we recommend continuing it before, during, and after the procedure. And again, just remember the split dosing.
Even in the interest of time, do you mind if I read you a question?
Yeah, sure.
From Sheila, after the acute stage, do you just go back down to the maintenance dose?
Yes, that's an excellent question. So you would just increase it by, it says up to 25%, but I would say increase the dose by whatever amount is convenient. So if your patient's on 2.5 films and it's just easier to increase it to 3 films a day for a week, then you can do that. But yes, and I have extended that for more than a week, to 2 weeks, sometimes even a month, depending on what the patient is going through. Like for my patient with the Crohn's flare, I think she will need more than a week of the higher dose. But yeah, you can just decrease back to their baseline dose. Good question. This is a algorithm that is on our website, and it was published by Rewrite the Script. I think it's really helpful for how to manage buprenorphine in the perioperative period. If the patient, if a patient is having a really major surgery, like they're going to be hospitalized for several days, you might consider holding their buprenorphine in that case, but I think you should discuss with anesthesia. So I will also give that caveat. But for most of our patients who go home that day or even the next day, we really try and keep them on their buprenorphine. There is, I will also say, still some debate over whether or not if the patient's on more than 16 milligrams of buprenorphine, you should try and taper them down to 16 milligrams before the surgery. And even in this algorithm, you can see if we follow, the side that says surgery with moderate to severe pain with a buprenorphine dose of greater than 8 milligrams, yes. Greater than 16 milligrams, yes. It says cap buprenorphine dose to 16 milligrams the day prior to the surgery. I do not do this. I have many patients who are on 24 milligrams of buprenorphine. I have them take 24 milligrams of buprenorphine the day prior to this procedure. And then the day of the procedure, I have them take 8 milligrams in the morning. And then I have them take another 8 milligrams around noon, or it depends on when their surgery is scheduled. But sometimes on the day of the procedure, they don't take more than 16 milligrams, and that's okay. The day after the procedure, we have them back on their baseline dose of 24 milligrams. But I don't cut the dose prior to the surgery. I find that patients don't necessarily do well with that. They're usually, many of them are in pain prior to the procedure, and that's why they're having the procedure. And then they're also having a lot of anxiety about the procedure. And so the idea of taking a lower dose of buprenorphine is hard on them. So I do not do this, but I think it is valid to follow this algorithm and do that as well. And there are also some really helpful guidelines at the bottom of this algorithm on dosing, on pain management in the post-op period. But you can always contact us to talk about specific patients as well. That's all I have for the perioperative pain management. Again, I know it's very brief, and there are many, many scenarios I'm probably not covering in this very brief talk. But again, please contact us if you have any questions, and we're happy to help you come up with a individualized pain management approach for your specific patient. Okay, so that was acute pain and perioperative pain. What about chronic pain? And so taking a step back, thinking about chronic pain management in general, here are some sort of basic big picture steps that I would encourage you to work with your patients on. So first, identify and treat any local pain generators. What does that mean? So if the patient has primarily their pain is in their knee and they have terrible osteoarthritis, get them in to see the surgeon. Is physical therapy appropriate? Any injections appropriate? Great. Try and talk to them about considering those options. Or does that patient need surgery? Talk to them about considering a surgery to help treat their pain. And many of our patients with opioid use disorder are very wary of surgery because they know it will often require opioids. So I think it will definitely be helpful if you can get involved and talk to them about the steps that will help them be more functional and have less pain in the long run. Another really important step is identifying and treating any comorbid psychiatric illnesses. I tell my patients that I don't, if they have substance use disorder and they have major depressive disorder and they have chronic pain, all three of those things need to be treated before I think any one of them will significantly improve. Not always, but definitely for pain. If they are not taking care of their mental health and we're getting them into addiction treatment, I don't really expect their pain to significantly improve. So helping them understand the importance of not just thinking of pain as a silo, but as a more holistically and treating everything will improve their pain. Understanding the continuum for pain to opioid use disorder in these patients, I think that's important for the patient as well as the provider. Many times patients will come in to see me and they tell me they don't have a history of any substance misuse. And as I get to know them, I would argue that that's not the case. But then I have patients who come in and, they really it does seem like they have more of a picture of physical dependence. And so the treatment can be different for those patients. And so I think understanding where they lie on the spectrum is helpful. I talk to them about sleep. We all know that sleep can be hard to come by, especially when someone has recently stopped using substances. But sleep is very important for treatment of chronic pain. And so getting their insomnia treated in whatever way we can, which includes treating their substance use disorder, is really, really important for long-term treatment of chronic pain. And then talking to them about physical activity. Not all chronic pain conditions, but many really do. Patients do better if they start to engage in some sort of physical activity. And this can be difficult because many patients are really afraid of physical activity because it can exacerbate their pain. And obviously we need to take this on a case-by-case basis. But what I do for basically all my patients is I start by having them, especially when it's nice weather, just sit outside for a few minutes. But really, trying to work with them and make them understand that physical activity for most conditions that cause chronic pain, physical activity is really important for part of the treatment. I'm not going to go over this too much. I think this was part of an editorial that was really discussing the FDA guidelines. But I think I will highlight here in this middle column, if you have a patient that has chronic pain and they're currently receiving opioid therapy, I think we all know now that we don't want to abruptly taper or just discontinue their treatment without developing an individualized treatment plan that will if we are going to discontinue their opioid treatment, we need to make plans for how we're going to treat their pain. And we also know that in the next column over, for acute pain, we avoid opioid therapy whenever we can. And we try and, if we are going to prescribe full opioid agonists, the dose and duration should be limited. And the Start Talking form also reviews that. Okay, so if you have a patient who is being prescribed full opioid agonists, when and for which patients should I consider transitioning those patients to buprenorphine? So I would say you should consider transitioning patients to buprenorphine, your patients who are prescribed full opioid agonists, when the intermittent daily opioid dosing results in a real but only intermittent benefit. So this is a patient that will come in and say, you know, I'm taking this oxycodone 3 times a day, but it wears off so quickly and it's really hard for me to wait for my next dose. Or your patient that is on quote unquote a high opioid dose. I think the FDA had defined that as over 100 morphine equivalents in the past, or patients who have signs or symptoms of opioid adverse effects, which we reviewed earlier. Patients that are telling you that they need more, either they're having, you know, they're developing tolerance quickly, or there's misuse, potential misuse. So that patient that's telling you, you know, it's wearing off, I need more, that patient might do better on buprenorphine because buprenorphine is long acting. Or you have a patient who has some sort of severe other substance use disorder history. So if a patient, you know, had severe alcohol use disorder or some sort of severe substance use disorder, that patient might do better on buprenorphine and just might be safer on buprenorphine, taking buprenorphine. And so let's say you've identified your patient, and now you need to talk to them about buprenorphine. And so this talk is tough. Patients, even, you know, with or without a history of opioid use disorder, patients with chronic pain are often very hesitant to change their regimen. Even if the regimen isn't working that well and they're not that functional, they need to understand, you know, why you're suggesting this. And so these conversations can often take time. So be patient. And just keep reminding them all the benefits of buprenorphine and that it's an FDA approved pain medication as well as an addiction medication. And so just listen to your patients. I think there is some stigma with buprenorphine, which we've discussed. And so I think talking your patients through that as well, you know, yes, buprenorphine is used to treat addiction, but it's also used to treat pain. And it was FDA approved for pain before it was FDA approved for addiction. These are some of the things I hit on when I'm trying to talk to my patients about switching from full opioid agonist to buprenorphine. I really stress, maybe first and foremost, that I think it might control their pain better because it's long acting versus most patients are on short acting full opioids. And so many patients like the long acting opioid. They prefer the long acting opioid and they feel like doesn't wear off as much and that helps them control their pain. But I also, you know, tell them there's less risk of overdose, there's less side effects, there's less risk of developing an addiction or a tolerance to it. It's a Schedule III drug, so if they get, you know, become stable on it, I can send it in with refills. And then, you know, the disadvantages, which we've mentioned, are the cost and insurance issues. Sometimes the initiation, it's more complicated to initiate it. So let's say the patient agrees and the patient is ready to switch to, they're ready to switch to a buprenorphine product. So there is some debate on whether or not we need to hold the patient's full opioid agonist. I think it depends on how much of the full opioid agonist they are taking, what dose they're taking, and what you are switching them to. But officially, the recommendation is still to hold their short-acting opioid for 12 to 16 hours. And if you have a patient who is prescribed fentanyl or methadone for pain, You can switch them to a short-acting opioid for 5 days and then transition them to buprenorphine. And you can just email me if you're interested in that, what that protocol looks like. It was developed by Dr. David Cook at the University of Michigan. Unfortunately, we cannot bridge our patients who are using opioids that are sourced from the street, as it is illegal to prescribe a full opioid agonist for the treatment of addiction if a patient has a history of opioid use disorder. But if your patient is prescribed fentanyl or methadone for pain, we can bridge them with a prescribed short-acting opioid. So there's two FDA-approved forms of buprenorphine for pain only. The first is the transdermal patch, or the brand name is called Butrans, but luckily it's generic now, so it's much easier to get for our patients. Transdermal buprenorphine is rarely adequate for your patients taking more than 80 oral morphine equivalents of an opioid. So if you have a patient and you figure out that they're on more than, you do the conversion and they're on more than 80 milligrams of the oral morphine equivalents, unless you suspect they're not taking their full dose, this is probably not going to be a good option for them. We have a table here to help guide you to choose an initial dose. And the maximum recommended dose for the patch is 20 micrograms. For this patch, you can, because it's such a low dose, you can just start it and during the first day, taper them off their other opioid. So if they're on, 5 milligrams of oxycodone twice a day, you can give them 1 day of their oxycodone, so 2 pills, and you start the patch, have them take 1 day worth of oxycodone and then stop their oxycodone. Because this is a long-acting medication, unfortunately, it takes a week before we know if their dose is adequate. So please don't titrate it until the patient has been on the patch for more than a week, and they change it weekly. You can cut them too, just so you know. The other FDA-approved medication for pain, or other FDA-approved buprenorphine formulation for pain only is Belbuca. And it's a buccal formulation of buprenorphine. And unfortunately, this is brand only. And so it can be very, very difficult to get covered. But this is another good option, especially for your patient that doesn't do well on the Butrans patch, because if your patient is on up to 150 oral morphine equivalents, this is a good option for them. And again, we have the table here to help guide you on the starting dose. This is FDA approved, and the package insert suggests BID dosing, but many patients prefer TID dosing for this medication. And you can cut these films as well, just like you can cut our Suboxone films and the Butrans patches. And you can just start this medication and then DC the other opioid after 1 day as well. But again, this medication is difficult to get covered, unfortunately, through Medicaid and private insurance. So let's say we have our patient and we've been able to start them on the Butrans patch, and that didn't work until we transitioned them to Belbuca, and that isn't working either. And so I would say, try and go back, get a history. What isn't working? Are they less functional? And we want to try and focus on function instead of pain severity. Do they only get transient relief from the medication after it's dosed? We could consider increasing the dose or changing the frequency of dosing. If the patient is taking the sublingual buccal buprenorphine, just remind them, review sublingual admin technique. And I would say that I do this regularly, even for patients who've been on the sublingual medication for years, because sometimes I'm surprised what they're doing with their medication. I had a patient recently tell me that they put their medication in their mouth and it's so gross that they immediately chug their coffee. And so that patient probably isn't absorbing much of their medication because they really should not be eating or drinking while the film is dissolving. I would say also, if it isn't working, I would revisit the diagnosis for a substance use or opioid use disorder. go back and review these again with the patient, because maybe the patient does meet, the patient definitely has chronic pain, but maybe they also meet criteria for opioid use disorder. And in that case, they should be taking buprenorphine naloxone, the formulation. They should be taking Suboxone, which is, FDA approved for opioid use disorder, but we're going to use it to treat their pain as well as their addiction. Unfortunately, there's no expert consensus on how the different formulations of buprenorphine indicated for pain compared to the buprenorphine naloxone films in terms of serum levels. And actually, the literature I've reviewed is actually, it varies quite dramatically. So I would say just, you can't really look at it and convert, unfortunately. And in the past, insurance sometimes would not cover this buprenorphine naloxone or the Suboxone for the non-opioid use disorder diagnosis. That may be less of an issue now, as we're not required to code it under the X license, but I'm not sure about that, because buprenorphine naloxone for pain only is an off-label use. Here is a table to sort of guide you to guide you on how you could start their dosing. But I would just say, again, if the patient meets criteria for opioid use disorder, they will probably be at the higher end of this dosing. They might be closer to 16 milligrams even. And so you should take, all the bullet points, or all the, the patient's history into consideration when you're coming up with a starting dose. If the patient meets criteria for opioid use disorder and they have chronic pain, you might want to start them on a total buprenorphine dose of closer to 12 milligrams and just adjust based on, how well they feel their pain's controlled, their cravings, opioid withdrawal symptoms, and any side effects or toxicity from too high of a dose of opioids. I have a case here, but maybe in the interest of time, I will skip it. And this is, I think, my last slide. It's just briefly touching on naltrexone. The long-acting naltrexone, the effects of the long-acting naltrexone can be overcome with 6 to 20 times the usual analgesic doses without significant respiratory depression or sedation. And so obviously, these patients need to be in a monitored setting if there's some sort of urgent need and we need to overcome the naltrexone blockade of the opioid receptors. And you would want to consult anesthesia and have them in a setting that's equipped for resuscitation. I think there was a question earlier of if anyone's ever seen this, and I haven't, but we did have an ER doc once in our one of our trainings, and that person did tell us that once they had a patient come in who had been in a motor vehicle accident and they just weren't really responding to opioids, and they weren't really able to give a clear history, and they did end up dosing, up to I don't remember they used massive amounts of opioids, and afterwards they found out that the patient is on naltrexone. So I think just remembering to give all your patients with naltrexone the wallet card, or I think there's like a tag or a bracelet, and stress that the patient really try and keep one of those things on them if they can, in the case of emergency. So I will stop there and see if there are any questions.
While we're waiting, if somebody wants to type in the chat, please do so. I just want to remind everybody that we will email all of the attendees a PDF with the links to the 3 continuing education credits we offer. Just know that these credits expire on Sunday, September 10th at 8 a.m. So please be sure to complete your credits by that time. You'll also receive an email from your local behavioral health consultant in the next couple of days with all of the presentation slides. We want to thank the presenters, Dr. Hutchinson, Dr. Sethi, Dr. Morrow. Thank you so much. Thank you everyone for joining us today. And I hope you found this training valuable and enjoyed learning about this.
Thank you very much, and we'll see you next time.
Yeah, thanks for attending. Bye-bye.
See you.